orders, and mayoral emergency proclamation suspending and modifying requirements for in-person meetings. We are continuing to convene remotely, and public comment will be available on each item of this agenda. You'll have 3 minutes to speak. Roll call will now be taken to establish quorum, and we'll begin. Member Eisen was going to be absent today. Member Fields?
Present.
Member Gonzalez?
Here.
Member Hammer?
Present.
Chair Lassar?
Present.
Member Lipton?
I'm sorry, present.
Cool. And then member McWigan was not joining yet? Is that correct? Vice Chair Patterson?
Present.
Member Salinas?
Present.
And looks like member Short was going to be absent again today. And then member Wong.
Present.
Cool. So we do have 8 members. Out of 13, we have a quorum to continue. And then now we're going to vote to excuse an absent member from, and if we have any absent members. If the working group does not take a vote at the meeting or at a previous meeting, then minutes shall note that an absence is unexcused. Any member who misses 3 regular meetings within a 12-month period without the express approval of the working group at or before each of these missed meetings will be deemed to have resigned from the working group 10 days after the 3rd unapproved absence. Will be noted to the IWG as submitting and as an excuse. So members Eisen and Short did submit requests for this meeting as unexcused absences. Chair Lassar, are there any discussion notes that you want to have here before we vote?
Yes, I'm a little confused. They asked to be unexcused?
They have submitted, yeah. So they've submitted to request to be for excused absences.
Yes. Okay, thank you. Now I understand.
Any other comments?
Not seeing any hands, so I think we can move forward.
Cool. I'm going to now roll call and ask each member to vote yes or no to excuse these 2 members, member Eisen and member Short. Member Fields?
Yes.
Member Gonzalez?
Yes.
Member Hammer?
Yes.
Chair Lassar?
Aye.
Member Lipton?
Yes.
Member or Vice Chair Patterson?
Yes.
Member Salinas?
Yes.
And member Wong?
Yes.
Cool. We do have 8 yeses. We have a majority vote to excuse the absences. I think this is back to you, Chair Lassar.
Thank you. I actually have a different slide. 1 second, please. Actually, before we get started, I did want to just say Happy Lunar New Year, and also I wanted to acknowledge the horrible shootings that have been happening in the last couple of days, and the attack on the Asian American community, and just acknowledge that this is a lot going on, and on top of everything else that's been going on. So I just want to send out love to our Asian and Asian American community members. So thank you for that. I'm going to try to find why I have the wrong slide. Jen, do you mind just going ahead and starting so I can get on the right slide?
Of course.
Yeah.
Today we have 5 goals for today, and we're going to receive our usual updates from the director. We're going to review and discuss how we're organizing ourselves for 2023, so some concepts leading forward. We're going to brainstorm another community engagement project, and we're going to receive an update from the Office of Coordinated Care. They're going to be presenting on the Office of Coordinated Care and case management expansion together. And then we're going to vote on chair and vice chair for 2023. We've turned off the chat function for all panelists and the public due to issues of accessibility. So if you have any added comments or questions or concerns, you can use the email that we post, and that's something that we monitor on a regular basis. We encourage you to please take bio breaks as you need. Just go off camera, take care of yourself. We will need quorum to move the meeting forward, so you might just kind of eyeball who is here, who's in the room, virtual room, and when to leave and when to come back. So thank you. And Chair Lassard, sounds like you're back up.
Yeah, thank you, Ms. James. So today's meeting goals, we've already heard, but the next slide, please, is to remind us of what we're focusing on today and what our tasks are. So our job is always to advise on the design, outcomes, and effectiveness of mental health SF to ensure its successful implementation of the ordinance domains. Today we have our wonderful speakers. We have Dr. Hillary Cunnins, Mental Health SF Director, Valerie Kirby, and guest Lisa Aboud, and Deborah O from Interethnica for our community engagement conversation. And we have Dr. Angelica Almeida back from leave in her new role, and Director Heather Weisbrand of the Office of Coordinated Care. Next slide. We are now moving on to discussion item number 1 related to remote meetings.
As authorized by the, next slide, please. As authorized by California Government Code 54953E and the Mayor's 45th supplement to her February 25th, 2020 emergency proclamation, this meeting will be held remotely without providing a physical location. The state requires that we submit what they refer to as findings every month. These findings are that the IWG as a body has reviewed the teleconferencing meeting status in relation to the COVID state of emergency. The formal requirements titled Resolution Making Findings for Teleconference Meetings are posted to the IWG website, and by state requirement, we have to review and record our findings every 30 days. And please note that these emergency orders are going to terminate on February 28th. So we have 2 more meetings that are going to be virtual. In March, we will be resuming in person. So this fun that we have with our video conferencing will no longer be. So the 2 resolutions are as follows. The state of California and the city remain in a state of emergency due to the COVID-19 pandemic. At this meeting, the IWG has considered the circumstances of the state of emergency. And the second finding is that because of the COVID-19 pandemic, conducting meetings of this body and its discussion groups in person would present imminent risks to the safety of attendees, and the state of emergency continues to directly impact the ability of members to safely meet in person. Are there any questions about this resolution, its purpose, or findings? Okay, Chair Lassard, are you ready to open the floor for public comment?
Yes, Ms. Saika, please take us to public comment.
Sure thing. So members of the public who wish to provide public comment on any other on this matter of the agenda, call 415-655-0001. Access code for today, which is 2482-297-9271. And then you press pound and then pound again. So dial *3 to line up to speak. Gonna see if there's anyone in the queue. Currently, no one's in the queue. I'll give it a second. Since we have no callers, I'm going to close public comment. And I think we are now going to vote on those remote meeting findings. So do I have a motion to approve the resolution?
So moved.
Chair Lassard, is there a second?
Second.
Member Hammer. I will now call roll call, and each member should vote yes or no to approve these remote findings. Member Fields.
Yes.
Member Gonzalez. Member Gonzalez,
Yes.
Member Hammer,
Yes.
Chair Lassar,
Aye.
Member Lipton,
Aye.
Vice Chair Patterson,
Aye.
Member Salinas,
Aye.
and Member Wong.
Yes.
Cool. We do have 8 yeses, 0 nos. We have majority vote to approve the remote findings. Back over to you.
Thank you, Ms. Saka. We will now move on to discussion item number 2, approval of December 2022 IWG meeting minutes. These minutes are posted on the IWG website. Are there any changes to minutes as posted on the website? I'm looking for hands. Seeing no hands. Ms. Sadka, let's open up public comment again.
Sure thing. So members of the public who wish to provide public comment should call 415-655-0001, access code 2482-297-9271, and then you'd press pound and then pound again. If you haven't already done so, please dial *3 to line up to speak. Let me see if we have any callers. Currently, no callers. I'm going to close public comment. Now we're going to vote on these meeting minutes. Do I have a motion to approve the minutes?
So moved.
Chair Lassar, do I have a second? Can I have a second to motion to approve?
Second to approve the minutes.
Sorry, second to approve. I will now call roll call and ask each member to vote yes or no. Member Fields.
Yes.
Member Gonzalez.
Yes.
Member Hammer.
Yes.
Chair Lassar.
Aye.
Member Lipton.
Aye.
Vice Chair Patterson.
Aye.
Member Salinas.
Aye.
And Member Wong.
Yes.
Cool. We have 8 yeses, majority vote to approve the December meeting minutes. I'm passing it over to you, Chair Lassar.
Thank you. Next slide, please. We have our discussion item number 3, Mental Health SF Director's Update. And we have our phenomenal and fearless leader taking on a tremendous task. Dr. Hillary Cummins joins MHSF on a regular basis for updates. We're excited to hear what you have to share today, Dr. Cummins.
Hi, morning, everyone. Thank you for calling me fearless, Chair Lassar. I appreciate it. Morning, really great, of course, to be here and to give you my, this is my briefer director's report, so I'm not using slides. Just briefly, in terms of MHSF, and you'll get obviously a lot more during the meeting, and we look forward to the conversation. I just wanted to make sure everyone is aware that we, that is DPH, is required to submit our own implementation report for MHSF. I know we've been, there's multiple reports. The report is due February 1st. We are hard at work on it. It is supposed to be submitted to the Board of Supervisors and the mayor. The report contains some, mostly things that you all are familiar with: the summary of the MHSF structure, funding, our priority population and core metrics, milestones and accomplishments for 2022. And we are still in the process of setting program-specific and system-wide goals for MHSF in 2023. We intend to present more highlights from the report to the IWG at the next meeting and during my slightly longer update. So we look forward to sharing that with you. And I don't think we do not intend for there to be any surprises or really departures from what we have all been discussing and what you all know about. Just a quick comment, what's happened sort of importantly in the city since we last met. One important local thing that happened is that the Office of the Chief Medical Examiner announced preliminary overdose data for 2022. That preliminary number of overdoses is 620. That represents a decrease from the number, again, the preliminary number for 2021, which was 640, and a significant decline from the number in 2020, which was in the 700. So this represents 2 years of declines. In the case of 2022, a modest decline compared to 2021. Just wanted everyone to be aware of that. By no means are we calling victory. I just want to be clear. This is still an epidemic, and we are still working and implementing our overdose plan, which of course interdigitates. I think that's a medical word, which intersects and interacts profoundly with the work of the IWG and the work of MHSF. So we look forward to more updates on that and more details as they come out. I also wanted to share with this group some bigger picture work around the state, which I know that probably most of you are aware of. I wanted to share that I had the opportunity last Thursday to represent San Francisco on a paddle for the Bay Area Legislative Caucus, invited by Assembly member, former Board of Supervisor member Matt Haney. The panel focused on issues around mental health and regional coordination, particularly, and services in California. And I just wanted to share with the group what I and the panel discussed. I should also add my co-panel member was Secretary Dr. Mark Galley from California State. So it was instructive to hear also about his work and California priorities. Of course, in a group of legislators, we spoke about legislation and some of the bills that have been introduced or underway. I think, as you know, Senator Eggman is very actively involved with legislating around the need to modernize behavioral health care continuum of services, looking for multiple opportunities in order to strengthen access and availability of a range of services, as well as the ways in which we are able to track services. There was an interest in expanding and how we might expand regional approaches to coordinate care and share treatment slots. And I know this group, which I fully agree with, is really recommending in-county services, which is a priority for us as well, but also realizing that sometimes in-county is not possible or is not possible in the near term. And so temporizing solutions have been sometimes sought, as you all know, as we've sought to expand, but with an eye always to aiming for in-county solutions. That said, there is regional interest, and how that works through or plays out is very much still to be determined. One other challenge we've noted and which we shared is that, as you all know, Medi-Cal benefits are county specific, which imposes some challenges for us as a county in coordinating benefits, in transferring Medi-Cal benefits, which can take many months. And then finally, folks that we are collectively primarily interested in, people experiencing homelessness or impacted by the criminal legal system, may have additional challenges around Medi-Cal. So we did raise that. In terms of overdose at the state level, there are a number of legislative proposals under discussion. Most of them have not yet been formally introduced. So we have been trying to make recommendations around high impact interventions that we believe could continue to drive overdose deaths down. One of which is to expand naloxone supply by the state in order to achieve saturation of naloxone availability, as you know, which is an emergency medication to reverse an overdose, often in the hands of people themselves who are at risk for overdose, or in social networks who really are the most frequent and best responders in many cases. Naloxone supply, however, has been limited, and we are aiming to increase that distribution and would recommend state assistance. As you all also know, the city has supported establishing safe consumption in the city, and we were eager for state support and are hopeful that the state legislature will again vote for that bill. And then finally, our two last discussion topics at the panel is around Care Court, which we've spoken about some here. As you all know, San Francisco is part of the first cohort to implement that will implement Care Court in October. We are concerned, however, about our current capacity to absorb potentially additional clients, and the need we believe, to increase treatment access, and we're hopeful of state support, financial support to do so. Finally, and I know this topic is near and dear to all of our hearts, we discussed at the panel the challenges of the behavioral health workforce. I raised that our contracted providers, many of you, as well as city staff ourselves, are finding significant challenges to hire sufficient staffing as we work to expand treatment and recovery services. As you all know, or perhaps do not, the governor did initiate a number of workforce investments in the budget, and we are encouraged that next year's budget maintains these commitments. We understand, we've learned that the proposed workforce initiatives may be delayed due to a decline in state general funds that could put off some of the initiatives, including, and I don't have a ton of details about these, but I'll just name them: Community Health Workers Initiative, Social Work Initiative, Addiction Psychiatry, Addiction Medicine Fellow Initiative, University and college grants for behavioral health professionals, and MSW slots at public universities. These are all really terrific proposals that will be in the budget, but will be delayed. And I think I just want all of you to know that I raise this as San Francisco, but I'm also aware that it's really a statewide issue around the need for the legislators to be aware of this and how important this is for us to achieve our goals. Sorry, I'm a little froggy, but that's all I have. And I'm happy if there's time to try to answer some questions.
I think so. We are on time. We have about 10 minutes. I see Member Fields' hand and Vice Chair Patterson's hand. Then I'll raise my own hand after. Please, Member Fields. And also, thank you. That's a tremendous bit of work, and so excited on all these aspects. So, and also deeply concerned in some of them, which we'll get into. So, Member Fields.
Thank you. Good morning, Dr. Cunnins. I, like everybody who works in the field, was pleased to see the continuing drop in overdose deaths. And I'm looking forward to seeing the efforts that you and your staff have instituted with community-based organizations and to continue to bring that down. And good work for your department. It's a direction we want to see, but it's a hard one to affect. The one thing which I guess is going to be my theme for a lot of things as we come out of a lot of the COVID restrictions is, in the case of the care court implementation, what's the plan to kind of to ramp up the collaboration in person with the CBOs that are going to be needed to help implement some of the unknowns and the few of the very knowns about what that process is going to entail? Is there a plan soon to engage the community-based programs in actual face-to-face discussions where we can get down to a plan that we're all buying into and contributing to?
Yes, thanks, Member Fields. I know that is on your mind, and it is on our mind as well. Maybe finally is not the fair word. We now have an internal planning committee, and so we're sort of beginning to have some organizational structure internally, and so have been started meeting. I would say just a little bit with other city agencies, including our colleagues in HSH, including our colleagues in the judicial system, and I think we will working with community providers is on our very short next list. So stay tuned. I know you provided that feedback either last month or the month before. I think when we were I think still quite spinning around. And so, yes, so thanks for the thanks for the reminder, and we will get that done and are eager to do that.
Thank you.
Thank you, Member Fields. Were you complete? Yeah, thank you. Vice Chair Patterson, did you put your hand down?
I mean, yeah, but I still want to speak.
Please do. And then Member Hammer, please. Jamil, go ahead, please.
Yes. So I like how drug addiction is starting to be coupled with mental health, and I think the more that is spoken in that way, the better. You know, it's not always treated as a mental health issue by society, so I think that's good. And then also I like how we kind of started to address the mental health clinics a bit, because that's why you have long mailing lists. No, I mean long lists, waiting lists, is because of staffing. You know, the mental health clinics around the city struggle with staffing. So I like that we kind of started to look at that, and as Member Fields said, you know, we need to get the CBOs together. Some of those community-based organizations are the mental health clinics as well. So I would like to second that, and that'll be all.
Thanks. I just want to echo, and you all know this by now about me, just Member Patterson, thanks for bringing up the importance of what I'll call, I think this is consistent with what you just said, just the need to integrate mental health and substance use care. I think I'll go even further, the need to integrate physical health care, mental health care, substance use care where we can, in kind of what I'll say is a no wrong door approach. And we, including myself, train and grow up in, professionally in sort of siloed systems. And so it really takes a lot of us, whether we are leaders or frontline workers in a particular clinical setting, to really strive to do more integration. And thanks, and Member Patterson, you're championing that out both in the committee and in the rest of your life is part of what I see that all of us need to do. So thanks for raising that.
Thank you, Dr. Cummins. Member Hammer, and then I have a question too.
Thanks, Chair Lassar. I just wanted to point out this sort of a point of order, and I'm sorry I didn't raise it when we were approving the minutes, but the minutes from the December meeting refer to Dr. Cummins, I think on page 4, saying that overdose deaths have decreased since 2021. And in fact, as we heard from Dr. Cummins, and I think we really have to celebrate that we're starting to bend that really alarming curve with overdose deaths that we peaked in 2020 and have been decreasing since then. Obviously still have a lot of work to do, but I think it's just important for us to have the numbers right and to celebrate that we are starting to, I hope, have an impact on overdose deaths in San Francisco.
Thank you so much, Dr. Hammer.
So I don't know if we can just make that correction to the minutes, even though we already voted
Yes.
on them, or not.
I'm sure we can go back and fix that. And if we need to revote again next session, we will. So Dr. Cummins, thank you so much. I think in relation to the overdose deaths, you know my question, which I've already seen the preliminary data yesterday from San Francisco AIDS Foundation. In the new numbers preliminarily show an even bigger disparity for Black and African American deaths. And so I guess I'm wondering if there has been any conversation. So I'll put it as a multifold question. Has there been any more movement in a conversation around a media campaign or a social an engagement with community? What is the pathway for naloxone distribution now? How do folks access it, even in CBOs, especially given that sometimes we can find it, sometimes we can't. What is the pathway for making it available to community just off the gate? What's the easiest way, and what's that strategy? And what is happening in terms of the care court and the capacity, and then also the pipeline? So what is the delay in the funding, I guess, is what I'm wondering about, especially given that the state knows that it's such a crucial issue for us. The last point that I wanted to make is the safe injection site and the city attorney's position. If it seems very challenging right now, I don't know if folks have been following this in the newspaper or getting any reports, but it seems that what is being said is that they're asking for CBOs to take all the risk in actually opening up, and which means also the risk as far as being incarcerated or being prosecuted if for breaking a federal law. So I understand that there's some movement within the mayor's office and within the city, and also that you're probably in a very stuck place with this. But I'm wondering if you see any pathway through this current challenge, or what you see the pathway is, and what can we do for those of us who support a safe injection site do to actually move this needle forward with the city. It's very embarrassing that New York and other sites have been the first sites and not San Francisco. And so given sort of what we say we stand for. So just wanting to hear from you about that. And I think that also goes into this campaign piece around harm reduction and the social media and communications plan. So hopefully I'm making sense in putting all this together.
Thanks, Chair Lassar. Let me see if I can remember the different parts. That was the heart of many issues that we are near and dear and working on. Let me just talk about, and I think this is actually something that many of you have raised around the need for more external communications, public education, and I couldn't agree more, and we are working on it. I know I keep saying this. It is we are, have built out some additional communications capacity at DPH, which is very exciting. And we expect to be able to take that on and have something. I don't have a time commitment, but I agree wholeheartedly. And you may have noticed that we did do and will continue to do some social media messaging on risk reduction and mental health wellness. We did some messaging over the holidays on Twitter. We will continue to do that and develop sets of messaging in addition, but then that by no means is exhaustive, but that's where we have recently started. So if you're not following DPH on Twitter, please, I invite you to do so. And I hope you will start seeing messaging around issues around mental health and wellness and risk reduction in terms of substance use. So that is some progress I'm happy to announce. I need to review the numbers around racial disparities, and I haven't actually seen, so thanks for raising that, the San Francisco AIDS Foundation communication on that. I will look at that. Whether that is, if so, certainly going in the wrong direction, I want to make sure that we sort of analyze it the way we do every with other data. We, as I think I've also shared with this group, are intending, and it has procurement is slow for us, and we are intending to release mini grants for to focus on risk reduction in the Black African American community around overdose. I don't have the timing. I will bring to this group when that comes out, and we are aiming to include organizations and that haven't necessarily worked on overdose or on substance use, but have particular expertise in and cultural competency in working with Black African American communities. So that is our priority. Okay. Care courts. The situation of care courts in terms of funding is that the state has provided startup funding, but not ongoing funding. It is sufficient to start up the I would say considerable administrative functions that are needed. By administrative, I mean actually things that are reviewing petitions, assuring that those meet criteria and that the client is appropriate. That will require an assessment, and I'm using the term investigation, but I know that carries a lot of weight, but investigating a particular situation or person's appropriateness, making referrals, keeping track of those petitions that come to us and making sure that they are going through the process. All of this I'm saying very, I'm not intending to say this casually. We are just at the beginning of this work, working with our judicial colleagues, figuring out how much treatment capacity is needed. We likely have some funding for startup for some additional treatment capacity, but we are still needing to find budget for ongoing work. I think lastly, you spoke about safe or safer consumption spaces. Some of you may be aware that there was a hearing that Supervisor Hillary Ronen called, inviting the executive director of the New York program called On Point. That program operates 2 sites in New York City. The city attorney at this point has, given the legal risks and the balance of where we are right now, recommended what he has termed the New York model, which is there's public funding for wraparound services, adjacent services, but only private money is allowable for the actual consumption part. as Mr. Rivera discussed, to your point about risk, Chair Lasar notes that there's been, I thought this was sort of an important disclosure on the part of Mr. Rivera, that he's had non-public conversations with members of the federal government indicating support for consumption spaces. He did not name anyone, including members of what sounded like federal law enforcement. So I think in his judgment, the risk is low, to your point, Chair Lasar, about CBO risk. And I hear and understand your point very deeply. To me, there is opportunity for advocacy at the federal and state level, I think, to really contextualize, to sort of say that here's the context in which localities can successfully operate. And so I encourage that you all to advocate federally. There's actually a webinar, sorry, it's a different topic, but for those of you who have federal contacts or are members of organizations who might have federal contacts, I think really so important to hear from a wide swath of the behavioral health community, from the treatment community, saying that they support this as part of a broad continuum of care and services for people at risk of overdose. And that would be my recommendation based on what my understanding is of our local context.
Fantastic. Thank you so much. And I don't want to minimize the reduction in overdose deaths. One less is amazing and phenomenal. And the no wrong door approach is absolutely one that I think we all support here. I have Member Lipton's hand raised, and then I think we do have to move on for the sake of time. Member Lipton?
I'll try to make this quick. I'm very impressed, Dr. Cummins, by your comment about the meeting with the Legislative Caucus from the Bay Area. That's very, very helpful. And I'm just wondering, in your discussion about care court, whether there are planned to be discussions with the other pilot counties, particularly San Diego, Orange, maybe Stanislaus, Riverside, some of the larger counties, and some brainstorming among the pilot counties, looking for best practices, looking for issues. I've done a lot of work with some of the San Diego people before, even some of the Stanislaus people. So I think there's some good folks out there who are kind of, they all have their same issues, and whether that's on the table.
Absolutely. Thanks, Member Lipton. We are lucky that our County Behavioral Health Directors Association, CBHDA, who you may be familiar with, is convening regularly a cohort of the cohort 1 counties, including the ones you mentioned. So we are definitely speaking with our peer counties, and I know that's been really helpful to do all the things that you mentioned: problem solve, find out and create, dare I say, best practices, but really learn from each other as we are going along. So that's been great, and we expect that will continue through the implementation.
Good. I'll look forward to hearing more as this goes forward. Thank you.
Thank you, Member Lipton. And yes, I think we are all impressed with that. Dr. Cummins, could you also please share whatever webinar or other conversations, make sure that your team notifies us all as well, so that we can chime in, or anytime you're going to the Board of Soups or Health Commission on any of these issues, just so that we're aware and can be supportive.
Will do, and thanks for that reminder.
Thank you. Phenomenal work as always. It's not easy. We all really know that. Thank you for your commitment. We appreciate you.
Thanks. And I need to jump off for an hour, but we'll jump back on later.
Great. Thank you. Thank you so much. So next slide, please. Ms. Sadka, please take us to public comment.
Will do. Those who would like to provide public comment, call this number 415-655-0001, access code 2482-297-9271. Then you'd press pound and then pound again. And see if there are any callers. Currently no callers. Since there are no callers in the queue, I'm going to close public comment. Back over to you, Chair Lasar.
Thank you so much. Now we are heading into our discussion item number 4, 2023 level setting, where we, and to talk about where we're headed for this year. Please switch to the next slide and let me go ahead and shift this over to Ms. James.
Thank you, Chair Lasar. Yeah, we have a couple of just 3 slides that we wanted to go over with you that has to do with overall how we're organizing ourselves kind of conceptually, specifically how we're organizing ourselves by calendar, and then some questions for you about the upcoming retreat. So for the last 2 years, this relates to the overall concept. For the last 2 years, we've used this visualization to mark the domains that we're developing and their components. And at this stage of the Mental Health San Francisco implementation, the city planning team has recognized the need to better represent the vision of Mental Health San Francisco, especially in how it overlays with the rest of behavioral health services, treatment and services. And this is what also I know the IWG was recommending in their implementation report. Valerie, I wondered if you could provide some background on the conversations that about this that DPH is having.
Sure.
Thank
Sorry, I'm a little froggy as well. Hi, everybody. Thank you all for being here. So, yeah, among many others, have been saying every time I see this visual that it seems like it doesn't quite meet our needs. And I think we can do a better job of representing how Mental Health San Francisco is both overlaying and a part of our system of care, and how especially a consumer might engage with and move through our services. So we're very early in this process. We're just starting the conversation, but we want to try to get a new visual together. We want to make sure that again reflects how MHSF and the system of care are interacting with each other, and how a consumer moves through the system. But we know that that is often nonlinear, and there might be a lot of entry points. So that is the difficulty, I think, of creating a graphic. And I am certainly going to need assistance from somebody with graphic design experience to try to represent that. So, we may not be able to find a graphic that encompasses everything that we're interested in one way, but these are the considerations we're starting with. We also, I want to note, we use this visual for not just the IWG, we use it for lots of different audiences. Basically, every time we have to do a talk about MHSF. So we do want the new visual to both reflect your feedback, but also work for all those audiences. So we will be sharing a draft when we have that with you to get your thoughts. And I think that some of the mapping conversations, which I know are still underway, may help inform what would be a priority to include in the visual. Surprise to the comms folks listening in, I'm going to be reaching out. This is very early, to the comms team to see if we can use some of their graphic design resources. And I don't know what that capacity from that individual is or the timeline that would be available, but I think it would be useful to speak with somebody who has graphic design experience and see how they might recommend that we represent this. So more to come on that. I'm excited to share it when we have something to look at, and I'll give an update on timeline for that as well when I know more. So thank you.
Thanks, Valerie. Maybe before we move on to the specifics, are there any questions from the IWG for Valerie about kind of what they're working on and how it relates to this overall visual?
I'm not seeing any hands yet. I did want to note, though, that
Okay.
I have spoken with the team, the support team, the backbone of Harder and Company and the city mayor's office, controller's office, that that you all and we all have requests about these meetings perhaps looking different. So I do want to note that that hasn't been forgotten. We're not just wiping that conversation out of the way. We're hoping to get more in depth in that conversation in our retreat in March. But this is where we are at for now. So I hope that's helpful in setting some context.
Yeah, thank you, Chair Lassar. Okay, next slide, please. And so that's work that's going to be done on kind of the overall visual, integrating it with the system of care, thinking about a way to make sure that like we're connecting all the pieces and bringing it into where the design is right now. This timeline, we've had a timeline in our that we use to kind of sequence what's coming up with the next meeting. We present this at the end of every meeting. We also took a look at this after the IWG's implementation report was submitted and did some talking about it and trying to figure out how we can use these meetings most effectively for a variety of things. So this is just for comment today. It's floating an idea by you all. And the timeline is broken into 3 areas: the core components for mental health service, the middle section, which says in design, and then the last section is mandated reporting. So that first area that says the core components, these are similar to last year because it goes by what the ordinance says: the street crisis response team, new beds and facilities, office of coordinated care, mental health service center. And so, but we are thinking about it a little bit differently to represent the different levels of complexity in these different components. So in that first area where it says focusing on tracking recommendations, street crisis response team and new beds and facilities are listed there. And this is because these are 2 different components that are kind of contained projects in a way. They're still connected to the system of care, of course, but to be able to look at them kind of discreetly as the projects that they were designed. So for street crisis response team, they're on the road, they are doing what they are doing, and they were becoming 2 times, we're recommending them come 2 times during the year to give updates. This is what's happening. Get your feedback and go back in and do that work. And that'll happen on a regular basis in 6-month increments, or if something big comes up. New beds and facilities is similar to that. There's lots of little projects that are nested in that. And that's why there's this key at the bottom. You can see we've already designed drug sobering, crisis unit, TAY, MINA, the SOMA, and the expansion. Like that's the dashboard. So there are a number of discrete projects that were developed. And so we want to make sure that those cycle back to this group and you get an update about each discrete one, even though they're under this larger umbrella. So we're working with DPH on like what the sequencing of that would be and when the teams should come back. So we're thinking the next version of this, instead of X's, would actually say when different teams are coming to give you updates and to give some recommendations. Now below the next one, so that's just like recommendations about what's already been done. There's 2 big areas, Office of Coordinated Care and Mental Health Service Center, that are both complex projects that have lots of connecting pieces. And because they are much more complicated and they're system integration components, we wanted to make sure that there was really dedicated time to be able to dig deep into those. And those will probably take up more time, more of our meeting time. So right now, the Office of Coordinated Care has 2 X's in January, February, because like that's some deeper considerations that we're having for we're calling it part 1 and part 2 in January and February. And the mental health service center is still being deliberated, so there's no X's there. And Valerie, I wondered if you couldn't just speak a little context about why there are no X's there. Can't hear you, Val.
Sorry, I was muted.
There you go. Yeah, thank you.
So I can give kind of a broader update about where we are at BHS in terms of syncing up with this. I want to first acknowledge and emphasize that, as Chair Lasser just said, we know and we hear you that there's interest in changing perhaps the structure of this meeting, and I think that may affect both like how much time is available to present in different times, and also what you might want to hear about. I know there's some discussion about, establishing more working groups, and those might, take up some of the time. So we are somewhat in a holding pattern, waiting to hear what comes out of your retreat and directions that the IWG wants to go after you've had those conversations as a group internally in March. In terms of our process for calendaring when we're coming back, so this is tied to the implementation report that Hillary mentioned at the top. So to get us ready for our MHSF implementation report, we did a number of very in-depth visioning conversations with all of our domains and the components of our teams that are tied in with MHSF. Talking about like, what are your goals for 2023? What are the top things we need to accomplish and beyond, ideally? And so now I'm circling back to all of those teams to say, like, okay, we did our vision, we did our goals. When would it make sense in terms of your workflow and accomplishments to come talk to the IWG? When would it make sense to be presenting in order to get feedback on different things as we're implementing them, to get your recommendations? So that is the reason why a number of these are blank, is because we, one, need to get some more information about your interests and the direction you want to go with IWG, and two, need to finish our internal conversations to make sure that when we come, we have meaningful things for you to engage with, we have meaningful things to share. So that's where we are.
Thanks, Valerie. Let me finish the rest of the calendar, and then I'll turn it over for comments or some questions from the IWG members. The next section that says in design, these are kind of these foundational components that we pointed to in the IWG implementation report. There are things that need to be in place that are not just components, programmatic design, but they're things to make sure it's well designed, it's effective, it's equitable, and it's sustainable. And so some of the things that were mentioned, and we'll figure these out again, we'll be having lots of conversations coming up to the retreat and then at the retreat, but really about developing that mapping to inform the domains. So that's to make sure that everything is well informed, right? And you can see, like, we put some blobs of time for design of the mapping. That discussion group is meeting soon. Member Salinas is the captain of that group. And then we'll be using that, figuring out ways to use that to be able to design and refine those components. So it's going to be one of those foundational inputs to make sure that the overall mental health service, mental health San Francisco is well designed. We'll continue to review the analytics and evaluation work, and that's the overall effectiveness of Mental Health San Francisco. They've already come a number of times. So we put some placeholders for them to come back and continue to bring that information to you. There's the contributing to the staffing study, and they'll be coming, that's what the work that was started last year with the controller's office, and that's going to continue, and they'll be bringing that on a quarterly basis to you. And then we have this organizing, integrating, and optimizing resources. So this will take, I think this is going to be a big retreat conversation, is just because this has to do with the other systems that integrate with Mental Health San Francisco, the other funding streams that could be leveraged. So, and that's all TBD. The final section of the calendar just notes we do have one report a year that we'll be working towards. That's in October, just like we did this past year, but we're going to do a little bit more proactive planning to get there. So wanted to open up to the IWG and get your feedback on if you think this is headed in a good direction, and if there's any initial reactions to organizing ourselves this way, knowing it's a work in progress, but at least an initial idea. Member Patterson?
Yes, I have a motto that I use with my organization, and it's, you have to connect with local people, the local businesses, the local organization, and then of course local government. Now, I don't know if everybody's seen it, but there was a guy in the news. I think he was a business owner, and he had water hosed a homeless woman who was in front. Now homelessness kind of bleeds off into mental health as well, and I think it'd be good if we connect with some of the merchants and the businesses
Mm,
and maybe give them like a list of who to call,
mhm.
whether it's the street crisis response team. Like the guy could have called the street crisis response team instead of posing a woman.
Yeah.
I think he might have went through some options, but I don't know if he knew that one. And so, especially because I work in the Tenderloin, so especially down there, you can see this. Actually, you can see a lot of mental health work in front of a lot of businesses. A lot of people that need mental health, that camp out in front of a lot of businesses. So, and then it's not even just the Tenderloin; it's in other places too, like the Bayview too, a little bit. So I think connecting with the merchants, the local merchants. Back when I worked for the United Council, or actually back, my mom, when my mom had set it up, on the walls, there was information to services all around the city. And I think St. Anthony used to have this information too. So I think connecting that with the businesses is a good way to get it out there in the communities, especially downtown and in the Bayview and in
Yeah.
Fillmore.
Yeah, thank you for that. And what I'm hearing is one is like kind of better public relations communications to populations like merchants that maybe haven't been the target of some of DPH's communications work. I also, we're going to be hearing a little bit later on in the meeting about opportunities for community engagement. That's to inform your work. So Member Patterson, you might be listening for that when we hear the next agenda item. Let's Member Fields, then Lipton, and then Chair Lassar. Member Fields?
Yeah, thank you, Valerie, for the report and moving this discussion a little down the road. I'd like to just quickly contextualize some of this because I'm still concerned that we're locked into a framework that started with this domain conversation, which is, I've worked in housing development, everything. These are project-based discussions, not what kind of a system of care are we trying to develop? What's our goal? I still don't hear that. MHSF grew out of a discontent citywide with the status of our behavioral health system. Some concern that the existing health department wasn't addressing things aggressively and in a more comprehensive way, community programs that were frustrated, certainly consumers that were frustrated, both about the complexity of the system that didn't seem to be producing results. So I'm hoping that the department understands that we have an opportunity here to embrace the idea of describing what it is we're looking for in a system of care. My concern is that we're back to getting into the issues that got raised as specific things rather than talking about where the system of care is going. We were necessarily required to respond to the crisis on the streets that was coincident with the unfolding of MHSF. But I'd like to say that if we had done MHSF before the homeless crisis was so acute, it would have been just as valid because we act like that the crisis on the street and the tragedy of people not getting services, that they're a siloed group of individuals that came out of nowhere. It's a result of a system of care that did not have a commitment to recovery and people getting better all the way down the line, reintegrating into communities. There aren't clients in treatment and clients on the street as two different kinds of people. They are in their own continuum of a failed system of care. But I think we've been hijacked in a way by having to respond to the immediate crisis and then conflating that with developing a decent system of care that has a goal in mind, so that we get these individual projects that have, from my point of view, very little to do with developing a system of care that leads toward recovery, early intervention, and prevention. And we know what those continuum of care elements look like, and they're still not on the table. So our beds are board and care homes, laughingly called social rehabilitation programs, which is an oxymoron. A board and care home is not a rehabilitation program. It's maintenance housing that failed in the 80s, and we've gone back to it again because it's fast, it's easy to find a for-profit provider who will put it up in a minute. All the things wrong with some of the things we've been doing come out of the fact that we have yet to, I still want to hear the definition from the department of where are we heading? What is the purpose of the system? Is it maintenance care? Is it stabilization and maintenance? That's what we're doing right now. Everything is a crisis intervention with nowhere for people to go because we don't have enough other next levels of care for people. So are we just stabilizing and discharging, or we have a goal of recovery and integration into the community so that we can prevent the homelessness that comes from this polarity we have now of 8 days in a hospital and you go to a support hotel and you're supposed to deal with your substance use and your mental illness. So I'm hoping we can break out of these categories and talk about where we're heading as a system of care. And I'm fearful that this second chart again just picks up specifics like mapping and evaluation without talking about what's the point of this system. Thank you.
Thank you, Member Fields. Member Lipton?
Well, first of all, I want to thank Member Patterson for raising the issue that he raised. I thought it was an excellent introduction or initiation to talk about an issue that's been nagging me for some time, which seems that whenever there is a incident on the street, it seems that the local supervisor always knows about the individual. I know that Supervisor Modelman has a list. He knows who his problem, a lot of his problem constituents. I think in this case, I forget who was the supervisor, but it seems like the supervisors know about many of the individuals. And I've noticed from some of the reports that we've had, particularly on the crisis teams, street crisis teams, and I think also when we had a report on the Tenderloin Center, we seem to have a great deal of problem getting people into treatment. And it's not just inpatient or residential treatment, it's also ambulatory treatment. And strategies have been considered to try to improve the opportunities and the success of identifying people who need some level of treatment and to get them into treatment on some basis. I know this goes way beyond care courts. And I don't know where we go with this, but I think this has been a concern of mine for some time with the reports, and we ought to be looking at this issue and trying to address it. Now, it dovetails also with the director's comments about concern with care capacity, just with care courts, but it seems like this is the same issue and the capacity to probably do these things. But we need to figure out strategies or have strategies that where we know there are people who are, whether they're in crisis or just not even in crisis, but in need, how we move people from that setting to a treatment setting of some level.
Thank you, Member Lipton. I wanted to note, like, we are already 5 minutes over time. We have another slide to go. These are important conversations, and the conversations that we're having here, this is not going to be the only time. Like, this is the exact conversation we're going to be having when we have a dedicated retreat, which is the deep time to have conversation about this. So I appreciate the comments that you're bringing, which are kind of like related to kind of this initial idea of sequencing. and getting to some of these deeper issues, and the meetings that we're having that are leading up to the retreat, and then the retreat itself will be an opportunity to have these deeper conversations. Member Hammer and Member Salinas, you both have your hands raised. Could I request that you be succinct so that we can get to that last slide? Member Hammer.
Yeah, I mean, I was just gonna say that I really look forward to having deeper conversations so that we can all reflect on. I really appreciate what the three members all just said, and yet I have some questions to sort of challenge some of the concerns raised, and ask people to go deeper and say, you know, when we get like the Office of Coordinated Care, that really is the place where some of Member Field's concerns, where if we do it right, I think that we will achieve that what everyone's vision was when we started to imagine behavioral health transformation and mental health San Francisco. So I do think that the answers are here if we give input and make sure that we're doing these right. And then the last thing I'll just say is let's really think about how to measure success. So we're raising concerns, but how would you measure success? I would ask that of all the members who've spoken, like what's something we could measure to say we're achieving that goal, and then work with analytics and evaluation to make sure that we're really looking at the key performance indicators that we should be. So that's all I want to say.
Thank you, Member Hammer. Member Salinas?
I'll try and be brief. I would just like to say that I think, yeah, Ali is right. I think we can have a really important discussion later on the agenda when we discuss the OCC. And I think that one element that has been missing all along, is that a goal of mental health SF is a better integration of our system of care. But also what is missing along with that is that, instead of, we're having all these discussions of all these one-off programs, is that the population that we're dealing with has changed tremendously, particularly over the last 20 years, right? And so we're still working with the same resources and program designs that no longer fit a population that has changed significantly over time, and that we're getting more and more folks with really probably more primary substance use problems, folks with traumatic brain injuries, folks with developmental disorders, folks whose really primary diagnosis is not necessarily a mental health diagnosis. And so we're not getting resourced, and programs haven't adapted to this. And so this is something that, that we need to define. What is this? I think we've generally said, oh, it's this, SMI population, but, what do they look like? What are the needs they're presenting with when we go forward and thinking about refinements to our system of care?
Thank you, Member Salinas. And I think if you connect the two, like the first slide we had was an acknowledgement that we need to think about mental health San Francisco a little bit differently. Like the components are a little bit too discrete. They need to be connected. This slide is also trying to make some similar turns in how we think about it. It's still tracking what we've done, but also moving forward into this more integrated conversation that everyone is having. And we're going to do that in part through the retreat. So could you go to the next slide, please?
Ms. James, I think you forgot me, but I just want to highlight.
Oh, I'm so sorry. I'm so sorry.
Sorry.
Please.
I just wanted to comment really quickly on Vice Chair Patterson's comment, and really highlight also the Bayview corridor as well. And Vice Chair Patterson, I think through Rafiki and through Emoja Health, we could easily create some kind of postcard, and maybe I can also check in with you as well. So it's something that has just a very easy who to call in case of street in case of emergency. And I actually did one of these interventions along the corridor last week. And it was refreshing that one other agency or Open Door Legal actually knew the information to call street crisis, which is great. So I just wanted to, if Dr. Almeida is on the call, just let you know some messages are getting out. But the place that I was at, they did not know about the SCRT team, and so I think we can do a lot of intervention, and I'm very happy to do that along with the city, but also just as a nonprofit. So I'm looking forward to the conversation later, and would very much welcome anybody's input on what could be on just a basic little card that we can then go out and whether it's laminated or whatever, and help people put it up in their businesses. And so I just want to volunteer that, but hopefully we can also do it with how to access naloxone and how to access safe or testing strips for your for substances, et cetera. So wanted to add that, and hopefully we can put that on our outreach plan later with community outreach, but I didn't want to lose that momentum of what you're sharing, and also recognize that rather than penalize and create, obviously, I don't know how I feel about incarcerating the person that did that. I think that it's absolutely, horrific, and I think there's a level of anti-Blackness that is across the board in how folks are dealing with particularly unhoused Black residents in San Francisco. However, I think that there needs to be more of a reparative and restorative process versus a retributional process. And so I appreciate what you're sharing, Vice Chair Patterson, that there needs to be conversation with versus just a condemning of, is what I meant to say, not condoning, a condemning of. Thank you.
Yeah. And thank you, Chair Lazar and Member Patterson, for offering some like real-time immediate opportunities to address some of the things that are coming up as far as communication. And Chair Lazar, thank you for like noting that I did not call on you. Invitation for all of you if I ever do that. Next slide. March retreat. So we're not going to go, I think that in interest of time, what I'm going to do is I'm going to go over these different things that we're doing that are going to be we're working on and lift up some of the questions. There's one question I want to address specifically. The rest of them we will address through a discussion group that'll work on this. So logistics. Wanted to note there's not going to be a regular business meeting in March for the IWG. DPH is going to be using that for planning, and we can repurpose that time just for the retreat. So it'll be in-person retreat just with us, and it will be a public meeting. So there's a couple of things that we need to determine with that. One is, do we actually just use the date that's on your calendars and repurpose that meeting on March 27th, and that will just be for the retreat, or do we need to find another date? And we will need to determine, the question that we need to figure out is how to take public comment in the retreat. And now that we're going to be in person, it's a comment about what about the retreat and what about moving forward. So the specific question I have is there anyone that would prefer that we find another date other than the 27th?
Just point out it's actually the 28th, I think.
Are you serious?
That's the 27th is a Monday.
You're right. It is the 28th. Thank you, Member Fields.
You're very welcome.
So the 28th is anybody, could we go ahead and just use that time? Okay, I'm hearing nobody saying can't stand the 28th, it's a bad date. Okay, we're going to keep the 28th. We're going to move towards that. We would like to have, we need someone to help plan. So Member Lipton has raised his hand to help with the planning. I see, Chair Lazar has raised her hand. Would love others to come along. You don't have to respond now, but we will be putting out a request for you. Okay, Member Fields. I feel like I'm running an auction. Member Fields, Chair Lazar. And Member Lipton, and again, we'll put out this request for everyone, so you can always like jump into this, but this will be to help to plan this.
And
Oh, go ahead.
sorry, Ms. James, one thing I wanted to also offer, if you can't do a whole meeting for planning, if you have some ideas, maybe just send them. And also you can always call me or text me or whatever, smoke signal me if you have ideas and whatever you need.
Perfect. Thank you. And then I just wanted to list some of the potential topics that have come up. Deeper discussion of those opportunities that were in the IWG report. It's like just some time just to discuss that, as Member Hammer was mentioning. Connecting opportunities to that new concept. So what DPH is thinking about with connecting it to the system of care is, what is your reaction to that? Clarifying what the sphere of influence of this group is, like how much decision making, where are you going to influence things, having some conversation about that. Probably a conversation we need to match about the vision, the content, the process, and the capacity, because you're all graciously giving your time and you're all super busy. So we need to keep that in mind. And then, of course, as I mentioned earlier, we need to figure out just point of process is how are we going to handle public comment at regular meetings now that we're going to be in person. So we have Member Fields, Chair Lassar, Member Lipton. Member Lipton is, we need to figure out if one of you is interested in being the captain. Appreciate you all. Somebody else, if you want to raise your hand, that would be fabulous. We'll start organizing this group, and whoever else wants to come along, and we'll start bringing that back. So anticipate some communication about that. Any questions before we move on to public comment? Member Patterson, is your hand up? It's down. Okay.
You'd be on the planning committee.
Oh, okay, great. Thank you.
Member McGuigan's hand is up.
Yeah,
Okay.
I'd love to be on the planning committee as well. Just let me know dates of possible meetings before that.
Okay, we have 5 members. We can have we have one open spot before it kind of tips us into a public meeting. So if there's one other person, you're welcome to come along. We have a great
I
group.
would.
Thank you. Oh,
Jennifer, I would.
is that Member Wong?
Yes.
Yes,
Thanks,
okay.
y'all. Really, really, really appreciate the participation. Thank you.
All right, so we have it. And for those of you who are not going to be involved in the planning, do not fret. You will be involved and be giving feedback to this group. They're just queuing it up for you. All right, level setting or public comment, sorry. Ash?
Yes, so public comment, you'd call 415-655-0001, access code 2482-297-9271. Then you press pound and then pound again. See if there are any callers. Currently no callers, but I'm gonna give it a few more seconds. All right, I'm gonna close public comment. Chair Lassar, do you want to bring us into this break?
Excited for this part since it's been a busy morning. So 10:35 is our time now. We will be back at 10:40. Please remember to turn off your cameras and turn them back on when you are present. Thank you. And y'all, do you need me? I need just a bio break, but then I'm ready.
Got it. Thank you. Are you back?
Yes.
Ah, did you see my Slack post with the Jamboard link?
Again, I can't because we are on two computers here. If you can like send that via email, then I can
Oh, okay.
post the link.
Yeah. Okay. Here, email it to you.
Thank you, Member Gonzalez. Please do remember to turn your cameras back on when you're back, so we know if we have quorum again. It looks like we might have quorum. Let's see. Thank you. So shall we go ahead and proceed?
We're ready.
Wonderful, thank you. Thank you so much, everyone, for your participation. It's exciting to hear all of the hands raised for supporting our meeting planning. So thank you. We're moving into discussion item number 5, community engagement, update, and brainstorming. So I want to welcome Ms. Valerie Kirby, Special Projects and Community Planning Coordinator for Mental Health SF, Behavioral Health Services, and our community engagement partners at Interethnica, Lisa Abwood and Deborah O, to talk about community engagement.
Thank you, Chair Lasser. And just one slight correction, just because it's relevant for this presentation, probably. I'm not actually a community planning coordinator. I'm just a special projects coordinator. So just to emphasize that. So hi again, everybody. And I want to note here that I'm going to endeavor to get us caught back on time. So I'm going to cut things a little short here and try to make sure that most of the time is just used for you to share your ideas here and discuss. One sentence of acknowledgement previously that I know there is not time to comment and respond meaningfully right now. I want to note that I and others on our BHS team, we hear your comments shared previously. We are listening to you and we will have more to share. Okay, so moving on here. So I want to acknowledge that I have Deborah O here from Interethnica. They are our contractor through Harder to work on community engagement projects. I'm going to see how I can skip through here. So next slide, please. Next slide, please. We're going to just jump right to the discussion if we can. So we tried to get to this discussion previously, so this may sound familiar. We had to sort of shelve this for a little while because of meetings running long previously, but there is more funding available in our work to use toward community engagement activities. Those would be intended to support the IWG in informing your recommendations. To give you a sense of kind of how much we could do here with the money that's available. It can cover a couple of listening sessions or other activities of a similar size. I know we have a project started for the OCC around community engagement of the OCC, but this would be to take on new ideas. So we want to have a short discussion with you now. Going to still try to end at 11 to get your thoughts on what might be helpful to you if we were to do a little more community engagement work. What might be a focus that we could take that would inform your recommendations. I know just in this meeting alone, Vice Chair Patterson talked about engagement with merchants in the city. Chair Lasser raised a number of different community engagement pieces, including engagement to better address disparities in Black African American overdose deaths, resources for accessing street response, overdose prevention resources. And I know a couple we came in with just to sort of kickstart some discussion too. I think there is probably some room to further inform the development of the Mental Health Service Center that could function with community engagement. And also we hope as a part of our larger communications plans and efforts to continue our move from the very antiquated SFDPH site to SFGov. And we want to start with the pieces that are client facing. And so I think it is a priority for us to find out what the community needs to make that consumer friendly and engaging. So those are some of the ideas that I know have just been mentioned that we're coming with, but we want to get your thoughts. So next slide, please. So jumping right into the brainstorm, I know this is going very fast. We have a Jamboard ready. I think we'll take a couple of minutes to discuss or to post on this question, and then we can discuss. So really just what do you think the IWG most needs to hear from community around to make informed recommendations? We, you know, it could be on which domain, a program, population, key metric, and other ideas. So if we could put up the Jamboard, or I am not technologically savvy, if we could get into the Jamboard here. We'll take a minute to get your ideas. And I'll
pulling that up. Just give me a minute as we transfer shared screen.
And I think we'll do like 2 minutes on the Jamboard and then jump to discussion if that's okay.
Okay.
Thank you.
And members, you should have that Jamboard link in your preparation emails. So if you could go there now, that's how we'll enter the responses, and Ash will bring up the visual so everyone can see what's being posted that does not have a link, and she'll help dictate what's being placed.
All right, can everybody see the Jamboard and can everybody access it on their own?
We can see it. Is anybody having trouble? Please raise your hand if you're having trouble accessing it.
It looks like we don't have permission to edit, so we have to send a request to edit, or at least I didn't. So I just
Jen can just change the access. So
Done.
that everybody who has the link can edit.
Give it a try. Do you remember?
I don't have access either.
Okay, because if anyone with the link can open it and should
Yeah,
be able to edit it.
we can open it, but we can't edit it. Maybe if we go back out and go back in.
Go back out and come in, please. Thank you.
Jen, you've made everybody editors, correct?
Yes. I think they just need to go back out and come in and it'll reset for them.
Are we looking under related links and resources?
No,
No.
no, here, I will send back out the link in case you need it.
Okay.
Yeah, my link isn't working.
You know, guys, I'm wondering, given limited time, should we just have a discussion? And I'm happy
Sure.
to take notes. I don't know that we need to do the Jamboard right now.
Okay.
Unless anybody feels strongly they'd like to do that. So if I could just get some help from the harder team in addressing hands for facilitation, I'm wondering if
Okay.
any members would like to start off just sharing any
Well,
ideas.
Valerie, before we move on, could someone take a chance? People are re-entering. They came out and they came back. Let's give them a chance just to see if it works.
Sure.
Okay. Yep, it's in. Okay,
Okay.
people are in.
Okay, great.
Yep.
So let's do 2 minutes and then I will take a little time for us to discuss. Jen, if we can aim for like 11:05, just given technical.
Sure. I'll keep time, and Ash will narrate as things come up for folks who need the audio.
Thank you.
It looks like we got our first few sticky notes. Someone saying from those, this most affects. So peers from family members. We also see someone sharing that they'd like to hear from staff who work with the community and at risk. Somebody else is sharing that I think for the areas which are more blanket slates, like IE program not so much developed, like mental health staff, community would have a lot of useful input. Someone else would like to hear from direct care providers working with community. Also hearing from other programs that have success. Someone's expressing a challenge in that informed input part. If the VH Commission has been getting regular updates, they are a representative group and may be able to give more informed input. And then long-term survivors of these broken systems. We still haven't had a meeting with our city, our home, Prop C Commission.
Okay.
If someone else would like to hear from family members of the folks with SMI and SCD. Someone else likes the idea of getting input from our city or home too. A third for our city or home.
We have just a minute left. Are there any specific components of the design that you'd like to hear from, or are these like more broad or general?
We have said community CBOs that provide services to SMI population, such as St. Anthony, Glide, as well as input from acute settings such as PS, ER.
So Valerie, we are at time that you requested. Would you like to, what would you and Deborah like to do?
So I'm wondering if we can take a few minutes. Oh, I'm seeing more come up still, but it's a little too small for me to read. Ash, are you able to read that most recent one?
Yep. We might try to get input from providers of care in the city, not just BH providers, but hospitals, clinics, others who need to be able to access services by new mental health SF programming.
Okay. Thank you. So thank you guys. These are great ideas, and I love to see so much coming through so quickly. I'm wondering if maybe we can, oh, I see all the ICM and FSP providers in SF. So, okay. And specific health parity population or coalitions. Very good. Wow, guys, these are great. American Indian Cultural District, great. So I'm wondering, I guess if we can take a second, if anybody'd like to speak to this, who provided an idea here, if we can think about, looks like we have the most votes have been for OCO, or not votes, but we've heard OCO several times. I'm wondering if anybody who mentioned OCO would like to provide like any more specific nuance about maybe how we could focus a discussion with that group, like any particular aspect you're interested in hearing more about, or is this really like you would love to hear them bring up anything they want to talk about, or just noting that this is intended to help focus recommendations. So I think we are also curious from an implementation perspective to how this can translate to informing, how we develop pieces that still need to be implemented. So I'm wondering, OCO gets a lot of the same presentations that we share here, how maybe you feel like that group would further inform your work. I don't see any hands, but.
Member Salinas?
Well, as I understand, the funds that we have been using thus far for mental health SF have been all Prop C funds, right? And so I think just in measures of accountability, I know that within the OCO oversight are many of the folks who organize to actually write that legislation and get it passed by voters. And it included a 25% of the funds being allocated for expansion of mental health services. So I'm wondering what was their vision. So we're in a sense charged here, even though this was separate legislation, because we were using those funds with also working with them in what was their vision for, and it includes a lot of people that work with this population providing direct service work. So I think there could be a better collaboration.
Mm-hmm. Okay, that's helpful. Thank you. And I'm seeing, and my very old eyes are having trouble seeing all of the tiles up close, but it seems like we're having a lot of different groups pop up that I think are specific to different cultures, different communities. I'm wondering, just trying to group those together in my head. Folks like the idea of maybe combining those in some way, since we do only have funds for a couple of listening sessions, if we wanted to consider bringing representation from a bunch of different groups together to discuss priorities. Anybody who, I see hands from, I don't know, Member Salinas, if that's an old hand, but I see Monique, your hand is up. Would you like to comment on that?
Yes, Member Salinas, go ahead, and then I can chime in.
It was an old hand, sorry.
Okay. Thank you, Valerie. Yes, We actually, I'm the former co-chair of the SF HIP committee, and that's San Francisco Health Improvement Partnership, which has the ethnic parity coalitions, as well as all of the major hospitals and the hospital council, UCSF, DPH, all participate. And we actually released a health disparities report. And in that report, we spoke to a lot of these issues. I think that we could have perhaps a listening session with that group because they represent a lot of both the hospitals, the councils, the parity coalitions, et cetera. Because ultimately, I believe that the only way we're going to get to real fully integrated care is if we actually engage with all the different service providers, and we call them to, we call them to the table. Additionally, I think looking at what these other health needs assessment reports in the city are, because they're commissioned literally because they have that it's part of what we have to produce as a Department of Public Health. It's what Kaiser has to produce. It's what the hospitals have to produce for their accreditation. This is a way that we can look at and see the data and see who's working in these different areas. So I think combing some of the existing data sets would be really important. I think additionally, I would like to see us we didn't actually add the pieces. I don't see that Vice Chair Patterson added with the merchants and the business corridors. So I would like to add those as well. And also I would like to add some kind of, I don't know if it's, I know that the Human Rights Commission has pulled together various community members and nonprofits and things. So that could be another, I think they do a community meeting every week. So that could be another session. I think, wherever we can make the biggest bang for the buck in terms of getting the most people and the most folks that we don't normally get to hear from, I think would be really important. So I know I just said a lot, but that's where I'm at.
No, Monique, I think that's great. And just as somebody who's done qualitative research a number of times too, I don't ever want to you don't ever want to exhaust your participants in asking them things they've already been asked. You want to be additive and building upon work that's already done. So I really appreciate your comments on that. I'm looking at where we have agreement on other themes, and I know Ash or Jen, you've been arranging these as we talk, so feel free to call it out as well. I see a lot in here about sort of connecting again with our direct service providers, both in the community and in acute settings, and in FSP and ICM programs. Anybody who, I see actually there's a hand from Member Fields. I apologize. I'm trying to manage both. Do you want to comment on this before I wrap us on this?
Yeah, it occurs to me there's some timing issues here with what we're doing. I mean, there seems to be an implication in this that the IWG is the channel for and has the authority to implement things. I mean, we're going to hear a lot when we go out to the community. I kind of wish we had done this before we started deliberating with the Department of Public Health. I also feel like DPH should be listening to all these groups with us. I think we have to be careful that we're not setting up an expectation that until we have our own retreat and clarify, the relationship between the IWG and the department, we're kind of putting ourselves out there to gather a lot of information, but we don't yet have a structure and a way to take ideas that are even currently in the thinking of members of the IWG to put into implementation. So when we do this, I think has to be something we think about because it hasn't been done yet by anybody on any level, really. So you have the very technical problems of the coordinating the fate of OCA with us. OCA's got a diminished budget now because of the budget cuts going into the next thing. And we want to look for an avenue and a path for expansion of services in many other ways besides depending on our city, our home. But so does anyone else feel like if we were to go out and be sitting in a community meeting of people, we're going to get so many ideas that have been pent up, and we don't have a way to promise these groups what we can do about it. We're just like listening. We aren't a legislative body. We're not a funding body. We don't even have the final decision on what the quote domains and programs are that the department might be entering. So I think this is San Francisco. I think we have to be careful not to go out with an intention that makes us feel good, but that we may frustrate more of these populations than we're going to be able to see this as an avenue for legitimate input into the MHSF process, when even many of us on the IWG have some questions about how legitimate our input might be in this process. So I think it's a good start. I wish we'd done this in our first 2 months, so we had some data to bring to the discussions about what the public is saying. So when and where we do this, I think is important for us to consider.
Thank you, Member Fields. I wish I had more time to speak, but just for a clarification on process, I believe we're taking ideas now. I don't believe that, just from a workflow perspective, that these meetings, these listening sessions could occur until after your retreat. So there is a little bit of a runway there. These are going to be the projects that are performed by DPH with the support of Interethnica. So DPH will be listening, we will be present, we will be supporting the process of analyzing the feedback and sharing that with the IWG to then inform your recommendations. So that's the process that we're undertaking. And I thank you for your comments. I want to make sure that we allow time for our next presentation and that I preserve time for all of you. So I'm sorry this is somewhat truncated, but thank you very much for all of your thoughts. I think in terms of our next steps, I'm going to talk to the planning team and Interethnica and our leadership about what is feasible and make sure that we also too, I want to take a little bit more of a chance to look deeply at the information that you shared. I might have some follow-up questions for you to sort of narrow the requests. And I'm happy to provide an update in our next meeting about where we are in terms of selecting a topic and getting projects stood up. So thank you guys very much for your time.
Valerie, before you sign off, Monique, would you recommend having a discussion group in between meetings with DPH around this issue so that it's?
Yes, please. I would love
Okay.
to have a process with it. And Valerie, I wanted to let you all know in terms of the report that we submitted from SF with all the data points. The committee that was made up of from DPH was, I believe, under Susan Phillips' team, Dr. Susan Phillips' team in population health. So if we could maybe bring somebody along from population health as well to the conversation, I think that would help because they were part of the data collection as well.
Thank you. Okay.
Thank you. So we'll add that that discussion group to the list of groups, and we'll talk about it at the end of this meeting about signing up and all of that business. Ash, do you want to bring back up the PowerPoint and go to community, public comment?
Yep, so those who'd like to provide public comment would call 415-655-0001, access code 2482-297-9271, and you press pound and then pound again. See if there are any callers. Currently no callers in the queue. Since there are no callers, I will close public comment. Back to you, Chair Lassar.
Thank you, Ms. Sadka. We are now moving on to discussion item number 6, part 1 of the OCC and case management expansion update. My note section is blank, so I'm going to go down to the next slide and look at next slide, please. The agenda. So we're going to have a refresher on the OCC updates, definitions of care coordination, care management, case management, LPS, and voluntary holds. And then it looks like this is somebody's slide deck. That's probably why I don't have any notes. So who's coming to talk to us about that? Is that Dr. Almeida and
Yes, and Heather Weisbrod.
and
Yes.
Director Weisbrod. So can we go ahead and welcome them aboard?
Good morning. Thank you for having us.
Morning. Thank you for waiting and having us.
Oh, absolutely. Good to see everybody. I'll be presenting today with Angelica Almeida. I'll be doing the bulk of the presentation, and then Angelica will talk a little bit about LPS holds. And so our purpose in having this part 1, part 2 is to start to weave together how OCC and case management expansion of the system of care work together. So we'll touch on that briefly today, but the bulk of that conversation is going to happen next month. Today, I will be giving an OCC refresher just to remind everybody about the vision of OCC and the kind of the current structure, providing some OCC updates that we had been wanting to come and provide some information about. And then I know that one of the requests from us was our working definitions of care coordination, care management, and case management. So we'll share that with you. And then the other piece that we wanted to dive into today was our follow-up for LPS involuntary holds and kind of larger system approach to involuntary holds. I mentioned this in a previous presentation and that we are working on doing systematic care coordination and follow-up, and there are some larger system updates as well that Angelica is working on. So we'll be talking about that. And then plan for next month is to dive a little bit more deeply into the case management expansion and system of care and OCC interface. So with that, we'll dive in. If I could get the next slide. And then the next slide. So just as a reminder about Office of Coordinated Care, our overarching goal is to support equitable and low barrier access to behavioral health care, seamless transitions between systems and levels of care. If I could get the next slide. Our current structure includes 2 main components. The first is behavioral health access programs. These are existing behavioral health access programs that provide centralized access to behavioral health services. So they include the Behavioral Health Access Line, which is our 24/7 state-regulated phone line for accessing behavioral health services, and then our Behavioral Health Access Center, which is a walk-in center that provides support with connecting with behavioral health services. Our second large section, and one that we focused a lot on in here, is our care management and transition support services. So these include centralized care coordination and care management to support people who are making transitions between levels of care or who have needs that impact engagement in behavioral health services. And if I could get the next slide. I presented this, I think, a few months ago. So as a reminder, we often talk, when we talk about the Office of Coordinated Care and updates here, about 2 distinct but very related and overlapping components in the planning. So we have the Office of Coordinated Care, which encompasses those 2 components that I just talked about, and that's kind of the Office of Care proper. And then we have case management expansion, which has been happening under the planning domain of the Office of Coordinated Care, but much of which is being managed and expanded in our treatment system of care. And so and Office of Coordinated Care as well. So they're definitely overlapping. We wanted to demonstrate, though, that these are two distinct pieces of work that we are going to be covering in the next couple of months, and just show some of the ways that we're thinking about how these work together. If I could get the next slide. And then the next one. So I am going to be just providing 3 updates regarding Office of Coordinated Care that felt important to bring back here since our last meetings. The first, and I think I mentioned this maybe in a previous meeting, is that OCC moved to Epic on November 7th of last year of 2022, which is a huge piece of work. That launch date was about 6 to 9 months in the making of many weekly meetings and planning sessions and workflow design and a lot of work with a really incredible Epic team and staff who were brought on as subject matter experts. So we're really proud of that launch and really excited about what it's going to yield in terms of our work. As a reminder, Epic is an electronic health record. It's widely used across DPH, and BHS is going to be moving towards using Epic as well. And OCC is one of the first steps in that move to Epic. It's also widely used outside of DPH, so it's a definitely gold standard electronic health record. We use it for documentation of our work with clients and then also for coordinating care, and it has some really incredible care coordination benefits. Benefits of OCC moving to Epic include this specially built care coordination module that allows us to see at a glance connections to care providers, insurance status, hospitalization. I mean, a lot of tools kind of all in one snapshot. And so it allows us to see, to really effectively be able to coordinate care in an efficient manner. There are many really great provider communication tools in Epic, so we can actually communicate with existing providers directly within Epic rather than having to move to separate systems, which allows us to share charts and share specific protected health information with other providers within that electronic health record. And then the thing that we're really excited about, and I'll talk a little bit on the next slide, is our Epic is allowing us an increasing ability to obtain and analyze service data. So it has some really great data analysis tools as well as data capture tools that are pretty easily accessible to the standard user. So we're excited about our increasing ability to look at that and to be able to start really looking at who we're serving and how we're serving and moving towards being able to look at our outcomes. And then as a reminder, the OCC subcomponents that were included in this Epic launch are the behavioral health access programs, so Behavioral Health Access Line, Behavioral Health Access Center that I mentioned, our care management and transition support services, and then the Street Crisis Response OCC team, which provides the follow-up post-street crisis response contact. If I could get the next slide. And I'm going to run through a lot of detail here, I know. I think we're planning on getting through this presentation and then leaving a big chunk of time at the end so that we can have questions and discussion. The update for our Bridge and Engagement Services team, I think is related to data. As I mentioned before, we're starting to be able to look more closely at the data for BEST now that we're in Epic. There's still some work to do to validate the reports that we have and to make sure that we're getting the outputs that we need. But the things that we're starting to be able to look at are the numbers of people that we're serving, our referral sources, our demographics, information about the system utilization of our current, the individuals we're currently serving. So we can look at the number of ED visits and PES visits and hospitalizations in general that our population that we're serving have had, length of time enrolled, and then we're starting to work on outcomes. And really what we one of the major pieces that we want to know is how well we are doing at connecting people into our behavioral health system. So not just linking or referring to care, but actually connecting people. If I could get the next slide. The last update is just a report back on our engagement with criminal justice system partners. I know I've mentioned before that that was our next phase, really making sure that we are serving people who are coming out of custody and involved in the criminal justice system. It's a very large, complex system, as I know many of you know. And so we're working at various fronts to make sure that we're providing the support needed. We're working very closely with DPH Jail Health Services to make sure that we're not duplicating work that they're doing, and that we are additive in helping bridge people out of care that they might be working with while people are in custody. And then we're working with them to identify specific populations of folks that OCC can be particularly helpful with serving. We have started going to some system coordination meetings, including a kind of large system safety and justice challenge meeting and a jail population case review meeting. And we're convening a biweekly case conference with pretrial diversion. And so upcoming, we're looking for additional opportunities to provide care coordination for people who are leaving jail, making sure that we're really covering all fronts that we need to cover. And then starting to provide care management for justice-involved populations, which would mean providing direct best services. Some of that piece is pending hiring and additional staffing that we need in order to adequately serve everyone we need to serve. But that is upcoming in the next couple of months. If I could get the next slide. Okay, so I'm going to take a breath because I know we just went through a lot of updates. The next section I wanted to go into are the definitions of care coordination, care management, and case management that we discussed. I'm going to start on this slide because I find the visual helpful, but on the next slide there are some actual written definitions if anybody wants to follow along there. I'm going to start actually at the smallest circle in the middle, which are care coordination specific activities. And you may notice that there's a small circle labeled care coordination, a large circle, the largest circle labeled care coordination. And that's because really these are used in two separate ways. And it's distinct but related ways. So I'll go through kind of how we're thinking about this. One thing to say before actually I launch into these definitions is that these are our internal working definitions, and this is how we're approaching. We want to make sure that we're using the same terms when we're presenting to you. But they're not the definitive definitions. There is not kind of in the larger world, not a lot of consensus about the exact definitions of all of these terms, and they're used often interchangeably, and there is a lot of overlap between them, or they may be used in totally opposite ways. So really these are our own kind of organizing definitions. There are some references at the end that have contributed to our thinking in how we're defining these, if they're helpful. So starting with the smallest circle, which is care coordination, we're looking at these as kind of the individual activities that support our goal of well-coordinated care. These are activities that can be carried out by staff like from many different disciplines and different settings. Probably a lot of us have engaged in care coordination activities, and they're really a building block of care management, case management. So they include things like communicating with other providers or calling case conferences, doing chart lookup to make sure that people are connected where they need to be connected. So they're kind of these discrete activities that support well-coordinated care. Moving out to the next largest circle, case management. We're defining this when we talk about it as a service line within BHS programs, such as ICM and such as outpatient treatment programs. So it includes connecting people to needed services, supporting engagement and care, and of course, care coordination activities. It's very person specific and program specific, and it can vary in intensity and length and location of services provided, whether it's a long-term relationship or a shorter-term relationship. So it is there's a broad definition of it, but it is that service line within BHS programs. Care management, moving out to the next circle, is a newer term, I think, for our BHS system. And the way that we're defining it is really aligned, and the implementation of some of our new care management activities aligned with CalAIM enhanced care management. But the way that we're looking at it is a really systematic and intentional approach to improving health outcomes for people who are in defined populations. So we're really looking at specific populations of people for whom we need to do a better job of connecting to care and improving health outcomes. An example of that, people who have had multiple 5150s, people coming out of the criminal justice system, and people experiencing homelessness. So care management includes direct work with individuals to organize and plan care, connect them to needed resources, and then also this intensive care coordination. And the focus is on supporting people with complex needs to address both their health needs and then also the social drivers of health. And again, this is aligned with the CalAIM enhanced care management. And then moving out to the largest circle, again, we see care coordination or coordinated care. And this is within this definition, because we are using that care coordination word in two separate but related ways. It really describes our overarching approach and goal for making sure that people get to the right care at the right time, and that we're improving our delivery of behavioral health services. So it's broad, but it describes our approach to all of these smaller pieces that make up coordinated care. And again, on the next slide, there are the written out definitions, so if they're helpful for anchoring, but we did find this visual to be helpful. And I won't spend, I think, too much more time on this. We have a lot to get to, but happy to take questions. Let's see, maybe we can move to the next slide. All right. So now we are moving into our involuntary holds or 5150s, and I'm going to pass it over to Angelica to provide system updates on this topic.
Good morning, everyone. So I'm happy to be here with Heather today, and I'll share a little bit of information and some changes in the California law landscape, and then some things that are specifically happening in San Francisco regarding involuntary holds at a systemic level. And Heather will be talking a little bit more about that follow-up work as well. And just to echo what Heather said earlier, really our goal in presenting together both this meeting and the next meeting is to really show and highlight the collaboration between system of care and the Office of Coordinated Care, and how individuals will seamlessly flow through the system, including individuals who are exiting involuntary holds. So just to say, in terms of some state legislation that went into effect January 1st of this year, there's 2 Assembly bills and 1 Senate bill that affect all of California's work around this, and a lot of opportunities and guidance that this affords us. So to provide a little bit more information, Assembly Bill 225 is specific to provide some clarifications around due process protections for patients or individuals who are on involuntary holds, including clarifying that the 72-hour period starts at the time the hold is written, not when the person arrives at a facility or is transferred to a facility, but at the time the hold is written. The other thing that this really clarifies is some of the requirements of emergency departments to serve individuals who are on involuntary holds, including making sure that patients' rights is notified when an individual will be in a hospital setting, whether it be an emergency department or an inpatient unit longer than 72 hours. So again, a lot of opportunity for individuals to receive support, both through legal counsel and also through county patients' rights, and also to make sure that services are well coordinated for those individuals. This also may mean that individuals have hearings that are in emergency departments while they are placed on an ongoing 5150 or a 14-day hold. So there's some clarifications there and ways that we are working, and I'll talk a little bit more about that work momentarily, but with hospitals throughout San Francisco to make sure that this is seamless for individuals and they are getting comprehensive care regardless of where they are transported to. Assembly Bill 2242 looks a little bit different, and this is focusing on care coordination plans. And so Heather will speak a little bit to how we've already been working to implement, prior to this legislation, a systematic way to support individuals exiting holds. This provides some additional details and requirements and guidance for counties, including that there will be an implementation group to create a model care plan by August 1st, 2024. So that's when this legislation goes fully into effect. But it requires that and puts responsibility on hospitals to make sure that, and emergency departments to make sure that they are partnering with county behavioral health services to ensure that individuals are offered services and a plan prior to discharge, and requirements for the county to make sure that we are supporting and following up with individuals a minimum of 3 times to support bridging them into ongoing services. It also puts requirements on private pay facilities and insurance companies to make sure that they are providing comparable services to individuals. So we think that this is very exciting. We look forward to seeing the model for a care coordination plan. But again, there's already been a lot of thinking and work underway around this in San Francisco. So we are lucky to be ahead of the curve with Heather at the helm of that. And so more to come in the next couple slides around that. The last Senate bill that I just wanted to make sure I updated everyone around is Senate Bill 929. This is less focus on the experience of the patient and more around data collection and some new requirements as a county that we'll need to provide to the state on a quarterly basis, including number of individuals who are held for 3 days versus 14 days, et cetera, et cetera. And so I won't go into all of the details. But one of the new things that requires is also for us to, whenever possible, provide demographic data and to look at an analysis of any unintentional or disproportionate use of involuntary holds, particularly on people of color. This has been something that we've certainly talked about in San Francisco as we have a focus of equity, and that's central to our work throughout all of our programs. And so something we always want to be aware of. So we welcome these requirements from the state, from all counties to provide, and also allowing us to receive this information and requiring hospitals to provide us with this information so that we can look at this holistically and at a population level, look at interventions and how we partner with hospitals across our system to make sure that we are addressing the needs of individuals. Related to that, and again, pieces of legislation like Senate Bill 929 provides us with unique opportunities to partner with hospitals and requirements for hospitals to share information with us that sometimes can be a little bit complicated to receive from hospitals. In that effort, we are working with LPS designated facilities throughout San Francisco to update those agreements that will outline some of these new data requests and requirements of hospitals that serve individuals on voluntary holds to partner with the county to support individuals to receive services and a appropriate and clinically appropriate care coordination plan prior to discharge. And also what some of our responsibilities are as a county to address when there are gaps or failures in that happening. So we look forward to updating those agreements with the designated facilities. In addition to that, one thing that we are looking at is for facilities that aren't designated facilities like Kaiser Emergency Department, for example, of having memorandums of understanding. So we, again, can gather this information. We want to make sure that we have a complete view of what involuntary holds and services look like in San Francisco so that we can be much more intentional and informed in our work and collaborating with all of you on these projects. Related to that, one of the other things that we are working towards is in behavioral health services, 5150 training, or providing authorization for individuals to initiate 5150 or involuntary holds for assessment in San Francisco has been sitting with our quality management department for a number of years. And our goal to integrate this work into the system of care, the 5150 training will now be overseen by myself as the director of the adult and older adult system of care. Again, this provides us with a unique opportunity to really critically look at how involuntary holds are utilized in San Francisco, making sure that individuals who are initiating those holds are appropriately trained, and for us to have a quality management component so that we're addressing, again, the appropriate use of 5150s, how those can be maybe better written to support individuals to make sure that they are getting the right level of care when appropriate. So lots of work that's being done around this and around involuntary holds, but we look forward to providing additional updates. This is something where involuntary holds we recognize are at a critical moment for individuals, and so it is an opportunity for us to support individuals. It is the most restrictive care that we have, but it's a necessary part of our system, but we want to make sure that we are implementing these tools in a way that's client-centered and recovery-oriented, both at a population and person level. And so I'll turn it back over to Heather to talk a little bit more about the person level work.
Thanks, Angelica. If I could get the next slide. So as Angelica mentioned, we are getting a jump start on the new legislation regarding care coordination and care planning after an involuntary hold. We're really working and focus is on doing systematic care coordination and follow-up for people who have had involuntary holds. So pulling together those places in our system that do follow up to make sure that they're working consistently, and then adding additional resources where we need to. Our overarching goals are to make sure that discharge plans from the hospitals consistently include a solid connection to appropriate behavioral health services, and then that we as a behavioral health system are consistently following up for people discharged from involuntary holds. So as an overview of how we're approaching this work, it is a very clearly collaborative effort between OCC, between system of care, and between hospitals. Every one of those systems has a role to play in making sure that we are consistently and systematically following up with people after they've had an involuntary hold and offering them the support and services that they need. We're using data and new coordination functionality via Epic. So we're going to be looking very closely at rates of follow-up, making sure that we're catching those places and those places where there might be gaps, so that we can quickly address the gaps. And then there's new coordination functionality in Epic. In terms of some of the coordination that I spoke about earlier and the new coordination tools, but we are also building a report that's going to give OCC staff the ability to, on a daily ongoing basis, look at every single person who has had a 5150 hold, and so that we can start tracking and making sure that there is an appropriate discharge plan in place, and that we're really additionally focusing on making sure that we're following up with people who have had multiple recent 5150s or hospitalizations or jail contact, as well as people who are not connected or are very poorly connected to our system. So our planned interventions for the systematic follow-up include what I just described, which is that systematic review of involuntary holds. We're actually looking at every single 5150 as it comes in on a daily basis. We are making sure that discharge plans have a focus on connection to behavioral health care. We're developing tools for hospitals to use to make those make sure that people are connected to the appropriate level of behavioral health care, and guidance for them to make sure that they're connecting to that to the appropriate level of behavioral health care. And then we're implementing rapid follow-up post-discharge, which includes guidelines for, if there's an existing care team, guidelines for their follow-up for clients that they're currently serving. If somebody is not engaged, then being able to engage our current follow-up teams to make sure that they are, ideally, while the person is still at the hospital, engaging and helping to bridge the person back out into the community. And then we have some plans around what we call closing the loop, which means making sure and doing a double check that we're not losing anybody in that process of transition from the hospital to the community. So we are looking at data, as I mentioned earlier. We are OCC is going to be doing an additional set of follow-up for people who have frequent 5150s to make sure that they're connected into care. And then we'll be establishing case conference to follow up, make sure that there's follow-up for anybody who's referred to a program but does not engage in that program. Rather than the program dropping the person, we want to talk about it as a group.
Director Weisbrot, I was wondering, we have Member Salinas and Member Fields' hands. I was wondering if it might be related. I'm thinking it is around what you're just speaking on right now. Would you be open to that, or do you want to wait until you're finished?
I think actually I was just wrapping up, and I think we have just one more slide. So
Great,
maybe
let's do that,
that's
and
okay.
then we can take some questions.
Okay.
So please
Sounds
make
good.
notes, y'all. Thank you.
Okay, and I think Angelica was going to, I don't know if there's a lot to say about this slide, but I think
just really a preview for our next meeting. So in February, Heather and I will gladly be back to talk a little bit more about our work. Specifically, I'll be spending the bulk of the presentation talking about case management expansion and our countermeasures. And again, we'll really be looking at the flow of somebody from OCC to SOC and how there are intentional overlaps to make sure that people don't fall through the cracks, and how we'll be connecting individuals to services and making sure that we have complete follow-up for them. So again, more just a preview, but looking forward to coming back in February to discuss that. And then I think we can open it up to questions then.
I think it was Member Fields or Member Salinas first, then Member Fields.
Hi. Geez, I have so many questions. So I'm gonna try and I guess just looking at, so one on this, going back to the slide on engagement with criminal justice system partners, is there a specific team at OCC that will be working with the forensics population? Or is it a team yet to be created? And how will this team interplay with the current forensics providers, right? What will be the flow from that team then to the current forensics providers? Should I stop, or should I just do all the questions now?
I am happy to jump into that. Maybe we'll take them one at a time.
Let's pause after each question. We
Yeah.
won't test our working memory. So
Exactly.
Okay.
Exactly.
I'm pausing.
Okay. All right. I will test my working memory right now. It's the team that's going to be responding to criminal justice system jail is the same team. So it's the care management transition support, providing the same kind of service, which is that supporting people who are coming out of custody with bridging into care and into the community. And so that would include, where it's needed, best services. We are really conscious of not wanting to interrupt a flow that is already happening or working. So that's why we are working very closely with Jail Health to make sure that referrals that are able to get directly to forensic providers currently in existence are able to continue to do that. So I think that what we are looking at is addressing other gaps where those gaps are.
So perhaps folks that are in jail that need services but are not necessarily meet criteria for ICM,
Right.
for
Right.
instance. So
For instance, yes. Yeah.
okay.
And I'll just add to that briefly. I'll just say, well, of course, we have some specific and dedicated services in our system to work with individuals who have more complex contact with the criminal justice system. We want to make sure that all of our programs are able to work with individuals. So as people flow into our system, it won't just be with our dedicated services, but across our system of care and continuum.
I think I have questions and confusion about the definitions, but of the care coordination, care management, and case management. And I guess one thing I definitely want to point out with case management is that this definition is missing. So if you're including ICM in that, it's missing huge components of what we do, namely the treatment components, right? So there's nothing that, you know, this is definitely our case management components, which are heavy on care coordination, right? But it's missing that, you know, we're doing also treatment and recovery services, right? So lots of therapy, lots of group therapy, lots of psychosocial rehab activities, right? So I do hope that that can be included in what ICM provides, right? We're doing DBT, CBT, lots of rehab work, teaching people how to do their laundry, right? Teaching them how to take the bus places. So, I mean, these are huge components that take up a large portion of our time that are missing in the case management definition. And so I guess I'm just still you know, we do care management, we do care coordination, we do all of that. So is this, I'm wondering maybe is that what the visual is intent, you know, with these definitions, and encompassing, you know, they're not separate, they're all constantly back and, you know, it's a
Yes.
huge continuum, right, of what we're doing in case management. So
Yeah, and I'll just add, some of this, of course, is we want to make sure that we are all using language in the same way. And as you know better than anyone, terms have been used very interchangeably across our system. So this is part of our effort to level set when we're talking about different services in the continuum or different care points, what that means. And just to say, in terms of the case management and the treatment provided, absolutely, like case management is part of the service line of intensive case management, for example, but there's also all the treatment that goes into that. So there's the treatment piece and clinical interventions, and then there is the case management aspect and how those overlay with one another. So this is not meant to encompass or minimize all of the work that goes into that level of care.
and I think that another thing that's important to add is the increasing role that case managers are having to play of like ongoing outreach and linkage. So we're getting increasingly acute populations, right, that are ambivalent and towards services, right? And so just thinking about how our work is changed with the demographic, you know, the population, the SMI populations change over time.
Mm-hmm.
And that I don't think is captured here, and how we need to be resourced for that, right? That folks aren't coming to us, we're being required to go to them, and constantly needing, you know, if for any small little thing that happens, needing to provide incentives, you know, and these resources and much more work in the field and outreaching to folks. And these things are not reimbursable services, right? Like if we go out to search for someone for an hour, it's not reimbursable services, and it's not what is traditionally covered by Medi-Cal structured programs. And so thinking about next session, you guys are going to talk about expansion of services and really keeping in mind, in expansion, it's not just about expanding, how many case managers and so therefore how many slots are, but how we are bringing restructuring our programs currently to meet the needs of the changing population, and that this in and of itself potentially could help resolve some of the issues around retention of staff, right? That staff are very frustrated because our work is, we're not resourced, and, it's very disheartening when you don't have if you have this amount of clients and you're supposed to have, do all this, searching for people, and how unorthodox our work has become, right? And that we don't have the resources, and we're still supposed to be, if we're having 17 clients that are more acute now, and then there's never enough staff, so then you're having 22 clients that are more acute. How are you restructuring us so that we can better meet the needs of the clients that we're now having to serve? That'll help improve morale, maybe, and then hopefully we can keep staff, right? So maybe if we could keep staff, then we wouldn't necessarily need as many then we could reassess how many new slots and case management expansion that we would need. So just rethinking all the additional work that we're doing in case management, also that's not included in the definition of like this constant outreach, constant efforts of linkage for clients that are not actually asking for care, but that we are required now to try and engage. Because we have a lot of folks also that EMS6 is, we're constantly in communication with EMS6 about certain folks, and they come here all the time. That doesn't mean, if in the morning they're here getting meds and money, that, at 2:00 in the afternoon, they're not calling 911, right? So it's a very much more complex population. So they might even be engaged, and yet they're using tons of 911, and they're always, they're always at the ED at least, 2-3 times a week, and even though they're seeing us regularly. So I think that needs to be included in what is an understanding of case management now.
And I appreciate that. And of course, these are meant to be encompassing terms, and we'll be spending a lot more time talking about this in our next meeting. So I'm somewhat going to parking lot it for our next conversation. But I do want to echo something important that you said. And I think in terms of setting the tone for our conversation in the next meeting that I really appreciate is that as the Department of Public Health, as all of our contracted agencies, like we are the safety net. And the landscape in which we are serving people has changed drastically, which requires, and I think certainly in mental health SF, this is an opportunity for us to reorient our work, both as an organization and also as service providers to meet the needs of individuals. And so I think that there's a lot of opportunity for us to do our work differently and to think about our work differently. And certainly I'm newer in my role, but I hope with all of these programs under my oversight that we'll have a lot of opportunity to discuss how we move forward. Because I think that there's lots of opportunity there, and certainly the work has changed a lot, and I know that all of you feel that very deeply in your direct contact with individuals.
Jennifer, just a note that by the agenda, we have 7 minutes left for this agenda item, and Heather and Angelica, we want to be respectful of your time because it's important. So just keep that in mind as we move forward. And Angelica and Heather, do you need to move? Do you have a couple more minutes, or do you have a hard stop at noon?
I'll speak for myself. I have a couple more minutes, and I know that there's some people who have additional questions, but Heather, do you have a couple minutes, or do you have to?
Yeah, I have a couple minutes. I do have a meeting, but I have a couple minutes. I can push it back.
So let's plan to extend it till 12:05. That gives us an extra 5 minutes, 10 minutes total. So Monique, who is next? Is it
Member Fields and then Member McGuigan?
Thank you.
Great report. Thanks. As a member of the committee, I appreciate the seeing the detail and complexity that's going into this thinking. I wish we were doing it across our whole system of care. So Heather, you're doing a great job on this, and I look forward to it unfolding. I have just three quick things I want to raise now, and we can follow it up next time. I just on the hospital side, I'm assuming that you understand that a huge part of the clarity around what should be required for discharging 5150s, one of the major players in that is San Francisco General Hospital. I mean, you talk about hospitals, and we often talk about the privates and all the others, but some of the biggest problems in our experience of how discharge decisions are made, what criteria are used for a discharge having more to do with paperwork than necessarily, the ease of discharge. So I just want to clarify, you are planning to do a lot of this 5150 work with SFGH, I hope.
Yeah, and I'll just clarify. I think it's unfair to be critical of General Hospital when they're not here. And I also think that there's a lot of legal requirements that they have to abide by. This legislation and pieces of legislation I talked about are really looking at more of like when the clock starts for 5150 and how we make sure that we are coordinating and requiring both hospitals and private institutions across the board, and county and private insurance companies all have a responsibility and requirement to make sure that people are getting the right services at discharge.
Okay. It isn't a criticism. It's just a hope. Often SFGH isn't in the discussion around these things, and that I was just hoping that looking at their practices was also a priority.
We work with them
Yeah.
very intimately, of course.
Yeah. Have you been meeting with community-based organizations in the community in this process that have traditionally been receivers of 5150 discharges about how they view the system and what's working or not working? Is that part of the unfolding data collection?
Well, so just to clarify again, this is legislation that went into effect January 1st of this year. So 23 days ago. And so these are specific requirements around data collection, and data collection at the point of an involuntary hold. I think what you're speaking to is more around the services that people receive afterwards and engagement in care, and outcomes for individuals. That is something that we're looking at. That's not part of the legislation, but that is something that we look at on an ongoing basis. Heather, I don't know if you want to jump in around that, but that's something that's very important for us to make sure that people not only have an appointment for an appropriate service, but are appropriately engaged in that care and have connections.
Yeah, and again, I'm talking about, it's not the legislation. I think that's responding to a situation statewide that exists in the interface between hospitals and the community program. So I'm not talking about the legislation. I'm glad it's finally being written, but the conditions it's addressing have been conditions that have been a problem for a while. I am talking, though, about the quality of the discharge planning. You said yourself, Angelica, that you want it to be client-centered and recovery-oriented, not just a place to send someone. So I'm just saying that another important voice in that is the community programs that have traditionally been receiving 5150s and what they feel would strengthen that, which I think would help in a response to the legislation that we're talking about. So, and then finally, in the criminal justice interface referrals, it's the same issue with community programs. Traditionally, the priorities for discharge for reception, say at 24-hour programs, has been reduction of hospitalization and taking the pressure off the emergency room. And the need to be more responsive to people who are exiting jail is critical. But I think what we're going to need from that is guidance from the department with, again, the CBOs that do this to establish that as a priority. Because if you're in a position, say, like my programs are, of a bed available and a hospital referral comes and then 2 jail referrals come, clarity around how the prioritization of those beds in terms of systemic outcome is set, I think is still something we need to clarify in this ongoing discussion. That's what often creates the logjam. We haven't added new services necessarily, but we are necessarily finally addressing people coming out of incarceration. And we need to have some guidance around the relationship between that referral compared to someone exiting the emergency room or the hospital in terms of DPH's priorities. It's a matter of triage as much as anything.
Yeah, I appreciate that. And Heather, I'll just say, please feel free to jump in. The one thing I would add related to that is I agree, like there is an important piece of triage, and we also want to make sure that people are going to the appropriate level of care. And I think all of us as providers have experienced that sometimes we're problem solving for one individual. But again, really zooming out and making systemic changes to streamline things and clarify what the role is of different programs and making that connection so that we're not solving a problem for one person, and not to minimize, like we want to make sure that each person is taken care of. But again, we're making higher level systemic changes so that it's a system that works for everyone.
Yeah, I appreciate that. I actually appreciate the slide up. I was referring to the first goal in this presentation, to assuring that we're looking at that this isn't about just data collection. It says include solid connection to appropriate behavioral health services as a part of discharge. I'm hoping that's a standard that is embedded in this work around 5150. And that was my issue, to make sure that's consistent. Thank you.
Thank you.
There's 2 more comments in 5 minutes, Chair.
Yeah, I wanted to note we have Member McGuigan and Vice Chair Patterson. Member McGuigan.
Yeah, thank you. So I guess my questions are more on the front end. That we talked about, there's going to be 5150 training, and the new legislation, maybe you can just educate everybody on what qualifies as a 5150. Out in the field, if we talk about merchants calling, or if the street crisis response team is being called out for merchants. When can we 5150 people? What are the qualifiers on that, and who's allowed to kind of make those decisions, right? So how are we helping out our community and business members and people that want to help people but don't want it? I guess is kind of my question.
Yeah, and I can speak to that briefly. I feel like that's a 4-hour presentation in and of itself, so I won't delve into it in too much detail, and happy to come back at another time if that would be beneficial. But just to say, like programs like the Street Crisis Response Team or comprehensive crisis programs, we really want to make sure that community members have access to those programs and can connect with them if somebody's experiencing a behavioral health crisis. We, of course, as the Department of Public Health and as the city and county, take involuntary holds very seriously. It is removing somebody's choice around services or an evaluation to determine if they need involuntary care, and is, again, considered some of the most restrictive care that somebody can experience. And while we do everything we can as a system to be trauma informed in this intervention, we recognize that this can be traumatic for individuals. So we want to be very mindful around that. The legal threshold for somebody being placed on an involuntary hold is if due to a mental, it's a mental disorder in the legislation, but somebody is imminent danger to themselves, to others, or grave disability, which means that they're, and again, this is very nuanced, so I'm very lightly touching on this, and but that somebody's unable to care for their basic needs due to a mental health condition. So all of that to say that somebody always retains the right to refuse services or care, and there are certain circumstances that allow for us to initiate an involuntary hold or an assessment for an individual to see if they need involuntary services or intervention. All of that is done in a very short-term way and is evaluated on a regular basis by a court where somebody has representation to make sure that it's appropriate for them to be there. Which probably barely scratches what you're asking for. And I'm happy to, feel free to reach out to me, or I'm happy to talk offline if helpful, but all to say that we have these types of programs like Comprehensive Crisis Services and the Street Crisis Response Team as a resource. We know that there are many community members who are in need, and caring community members who are worried about individuals who are their neighbors. And we want to make sure that we are leveraging those tools and those assessments and ability to follow up and support individuals somebody may not need involuntary services, but we do look at each contact with a person as an opportunity to engage them in services.
Great. I know we're short on time at a 12:05 here, and there's another member comment. So I'll try to follow up with you offline on a different thing, but I think it would be good to maybe review this for about 5 or 10 minutes at one of the future meetings so people really understand the struggles that we have on getting the people that need the mental health to get them the help, because we're very, very handcuffed, and getting the people that need help, the help is very, very hard. So I'll table that, but I really suggest that maybe we can talk about this for about 5 or 10, 15 minutes at one of the follow-up meetings.
Thank you. We can just make an official request, Member McGuigan, for the next time that Dr. Almeida and Director Weisbrot are here, that we dig into this more.
That would be great. Thank you.
Thank you. We have Vice Chair Patterson and Member Lipton has now raised their hand as well. Can you all just make it quick? Because I know we're trying to move the time, but also it's really important to hear from you.
Actually, member McGuigan actually kind of covered what I was going to say. I mean, I actually seen an incident, where the mayor was walking down the street, and it was somebody that was outside that was homeless, and I actually knew the woman because she was at a shelter that I was at, and she wanted to be right there. She preferred that than to be told what to do. So, like, these are things that, we just don't be aware of. And I think we got to figure out how to handcuff ourselves or how to deal with that. There's a large percentage of people that's out there that's mentally ill that just want to be out there. So I land the plane there.
Thank you, Vice Chair Patterson. Member Lipton?
Okay, I'll be very quick. I mean, the whole subject of 5150 and the care coordination has become a huge issue for hospitals. Yesterday, the California Hospital Association had a webinar on this subject. They had over 900 sites in which people signed up. So it's a huge issue and of interest to hospitals. I have a couple of quick questions, one of which is, and we don't have to address it at this meeting, but historically, as much as we want to get people into healthcare and into the mental healthcare system, 5150s have also historically been abused. It's often, in some cases, it's been used as a means of just detaining somebody for no other reason. Many times, well, other than usually law enforcement reason, or used inappropriately for individuals who have medical issues that mimic mental health crises, but are not a mental illness based. And I'm just curious, and maybe you can address this at a future meeting, how care coordination is going to work with facilities to address the inappropriate use of 5150s that I think historically occur. And the last thing we can address at a separate meeting is how you're going to work with providers, with individuals who present to hospitals or to other facilities who actually are not county residents, and how this is going to work across county lines. We're happy to discuss this in the future, but I think these are issues that we're going to have to look at some point. And I agree with Member McGuigan. I think a quick primer on involuntary holds would be a very good thing.
Well, I'll jump in and just say I appreciate all of that. I think it is very important for us to look at all of this critically. And I appreciate you highlighting how involuntary holds have historically been misused, and there is a risk of that. And that's something, again, we take very seriously. In terms of individuals who have authority under the Director of Behavioral Health, under Dr. Cunnins, that is something that we will engage in quality management activities to pull 5150s that have been written and to review the appropriate use of 5150s. We always have discretion to revoke somebody's authorization to initiate holds. So that's something that we'll look at. Just to note, though, that the authority that law enforcement has to initiate involuntary holds is something that's in the Welfare and Institutions Code. It is not under our discretion. So how that's utilized, although we do partner very closely around that and support training whenever possible in discussions. Heather, I don't know if you want to speak more around the coordination piece.
Jill, can I just stop you for
Oh,
one
please,
second?
yeah.
On this issue about wrongful holds, and I realize that law enforcement is not under your jurisdiction, but it's a really critical problem for hospitals. And I will tell you, I represented probably 24 hospitals throughout the state who were cited for patient dumping because of an inappropriately written 5150. And so it's a huge issue, particularly when the hospital is stuck with a patient that has a 5150 moniker or designation from law enforcement or someone else, and they can't undo it because they don't have the authority to release the hold. So I just want to highlight that because it is a huge issue, a huge issue, both from a patient standpoint and a system standpoint.
That's helpful. Thank you.
I
Feels like
think,
a,
go ahead. No,
well, I was just
please.
gonna say this feels like a bigger conversation, and I can certainly talk about the care coordination function of it, but I think that it's what we're talking about is probably a little bit more at the front end. We certainly can surface issues as we're seeing them after people are discharging, as we're helping with discharge planning, and bring those back to Angelica and to the system. But it does feel like this is a kind of a front end issue to talk more about.
Thank you. And I think there was one more slide. Oh, thank you for the references. Are you all complete? Are y'all finished?
All done. Thanks for having
Yeah,
us.
I think so. Thank
See you
you
next
so
month.
much.
So thank you so much.
Thank you.
Director Weisbrod and Dr. Almeida, we appreciate you so much. And it's excellent that we have you here and we look forward to continuing the conversation. Thank you so much. And thanks to all the members with all their amazing and important conversation and comments. So we can move on now to the next slide. We are, Ms. Daka, can you please take us to public comment?
I sure can. So 415-655-0001 is the phone number and the access code is 2482-297-9271. Then you press pound and then pound again. See if we got any callers this time. Currently no callers. So I think I'm going to go for it and close public comment. All right, over to you, Chair Lassar.
Thank you. I believe it's actually back to Jennifer.
Yep, if you could advance the slide. So we're going to be voting on chair and vice chair, and there's a process that we're going to discuss and take that we're gonna follow through. But before we do that, if you could please move to the next slide, Ash. Want to say a big thank you for Chair Lassar and Vice Chair Patterson. We thank you so much. We have so much gratitude for all that you have done to support this group. Your guidance, your dedication, being here with us, helping guide us. It's just very, very much appreciated. And we hope that you will stay on if you have the capacity to do so. And I will ask, can everyone unmute yourself? Yeah, go ahead and unmute yourself. And on the count of three, let's clap our hands as applause for them, for all their stuff. 1, 2, 3. Thank you so much. All right, so this is the process that we're going to use. It's similar to the very first time that we did this. And we had sent out some reminders before this meeting. We are going to first take the hands of those who are interested in the chair or the vice chair position. I'll take down those names. then we're going to go in alpha order for people, whoever raised their hands, to give just a 2-minute statement about why you're interested in the chair, the vice chair, or either. And then we will do a poll. And the poll, just like we did last time, the poll is going to be whoever gets whoever gets the most votes will become the chair, and then the next one will be the vice chair, and then we'll vote. So that's the process we used last time. Any suggestions for changing that?
Can I just ask for clarification of whether Chair Lasar or Vice Chair Patterson is interested in serving again? And also, I want to say thank you so much to. I know this is a lot of extra work.
Yes, I will, I'd like to see this process through a bit more.
Okay. Vice Chair Patterson?
No, I'll be stepping down.
You'll be stepping. Okay. Thank you. Big thank you, Member Patterson, for everything that you've done. Just looking at hands. Okay.
I think Member Lipton raised his hand.
Okay. Member Lipton, are you raising your hand to be chair, vice chair?
No,
No.
I think I was not a member of the committee when you did this the last time. But if the current chair is interested in continuing, and unless there is objection, it would seem that we should confirm Member Lasar as chair and then move on to vice chair.
Okay.
Thanks so much, Member Lipton. That's exactly the process we did this last round. So we thought that it would be kind of to make it a little bit more like open for others in case they wanted. We wanted to open that up this time, but thank you for that.
Yeah. Well, and it does sound like, Member Lipton, you're making a motion to maybe separate that and say, you're making a motion for us to vote in Chair Lasar for another term and then just focus on the vice president. Is that correct?
Jen, you're very perceptive.
Okay, so you made a motion. Is there a second?
I second.
Okay, and that was Member Wong. Okay, so we have a formal request. This will be a formal roll call vote to vote Chair Lasar in for another round. So Ash, would you please do the voting for chair? The vote would be for yes for Chair Lasar to continue as the chair.
So we're not doing a poll.
Not now, no.
Cool. All right, so we are moving down all the way to the votes. We'll now vote to approve that.
Well,
right now we're only working with the chair. Yeah, we're only working with the chair. So this is Chair.
Ash, can I pause you? Ash, can I pause you? Because we're making this change in process. Oksana, do you know, because we had public comment, do we need to do public comment? So maybe we hold this and see who else is interested in the chair, vice chair, because this is kind of going out of order.
Sure, maybe we can just do the both elections for chair and vice chair and then open it for public comment. Does that make sense?
Okay. Okay, so we'll switch them. Okay. All right. Sorry, Ash, I wanted to make sure that we were right with our process. So we're going to vote and then invite public comment. Okay, go ahead.
And right now we're only voting to approve the chair because that's all that we have currently. Is that correct?
Yes.
Do I have a motion to vote on the chair? I'm doing this again. Jen already did it, but please, one more time.
So moved.
That's Chair Lasar, and then who's the second?
Second.
Cool, Member Hammer. I'm now going to call roll call and ask each member to vote yes or no. Member Fields.
Yes.
Member Gonzalez.
Yes.
Member Hammer.
Yes.
Chair Lasar.
Yes.
Member Lipton.
Emphatically, yes.
Member McWiggin.
Yes.
Vice Chair Patterson.
Yes.
Member Salinas.
Yes.
And Member Wong.
Yes.
Cool. We do have 8 yeses, which is a majority vote to elect re-elect Chair Lasar. So now we need to figure out what we're doing with the vice chair.
That's right. And just as a point of celebration, which we should always celebrate, everybody unmute yourself and let's snap this time. So this is for Chair Lasar for continuing to dedicate her time to us. So unmute yourself and snap. And thanks. All right. Now on to vice chair.
I have to say though that Member Lipton had the official like 60s snap going, so I vote for your snap.
Right, vice chair, is there anyone who would like to raise your hand for vice chair?
Can we nominate?
Why don't we first see if there's any
Okay.
hands? I see no hands. Chair Lasar, nominations?
Well, now I feel bad because I never want to nominate somebody that doesn't want it. So I'm not gonna do that process. I'm just gonna say that Member Salinas, you have spent a lot of time working with us anyway. So would you like to officially join the team, or if you are?
I was also gonna offer a similar nomination,
Oh.
Chair Lasar.
However, if you really can't, then I really want to acknowledge and honor that.
I have not yet made a determination whether my term ends at the end of May, and I have yet to make a determination as to whether I will continue to hold a seat, I guess is how you would call it. So I can't say that I can commit to that role at this time. Thank you very much for both of yours vote of confidence.
Thank you. Similarly, Member Wong, you have also spent a lot of time over the course. Are you interested? I'm just going down the list of who's been in the subcommittees the most. So, and then after that, it's Steve. So, I mean, well, it's the first Steve, then the second Steve. So y'all let me know. I'm going down the list.
Thank you, Lasar, Chair. I think I'm in a similar situation with us, with Member Salinas, where I think if my seat is up, I don't know if I can make that commitment at this time. But I definitely think either Member Lipton and the Member Field would definitely be totally a great great representative.
Come on, Shamil, why don't you come back? In a similar situation, I intend to be more of a provocateur than a consensus building person in this discussion. And I think that there are probably smoother people available who could do it better than I. So I don't think, and also because of the fact that every time we come up with programs, I have to recuse myself, that it's hard to have a vice chair who's recused in half the discussions that that the IWG has to have. So I will appreciate the almost nomination and have to say I decline it because I just don't think I'm the right person for that position right now. Thank you.
Okay, and we love a good agent provocateur. I do anyway. Why don't we do this? I'm getting a note from the team. Let's go ahead and postpone this vice chair piece because it's not clear that we officially need one right now. So we can postpone this to the next meeting and have folks think about it and see if they're going to re-up for the work or not. And then it'll also give our absentee members a chance to weigh in as well. Should I make that motion?
Yeah, please do.
Okay, I move that we postpone this vote to the next meeting for vice chair, and we also investigate whether we need a vice chair.
Second.
The motion.
Right, Ash, we need to do a formal vote roll call for this first, and then roll call will be for pushing this decision back and doing a little bit more work about what's needed.
Okay, so we're roll calling vote on this decision to push the vice chair voting back. Can I get a yes or no? Member Fields,
Yes.
Member Gonzalez,
Yes.
Member Hammer,
Yes.
Chair Lasar,
Yes.
Member Lipton,
Yes.
Member McGuigan,
Yes.
Member Patterson,
Yes.
Member Salinas,
Yes.
and Member Wall.
Yes.
Cool. We've got 8 yeses, the majority vote to push that voting of vice chair back.
Thank you. And, just a note to the group, we'll do some thinking in between meetings. Please keep in mind that the vice chair, the lift, is not as heavy as the chair. And so it's stepping in when Monique is unavailable or if she needs some additional help on something. So it's not going to be as heavy of a lift as what Monique does. So thank you, Monique, again. Moving on to the last public comment.
We've got 2 rounds of public comment. We still need to do this public comment on the voting of the chair. Also, before I say that, just, lots of like deep respect for all that you do, Monique. It's felt and I feel it always. So thanks for being down to continue doing this. Public comment for this discussion item, you'd call 415-655-0001, access code 2482-297-9271, and then you press pound and then pound again. See if we've got any callers. No callers, so I'm going to close public comment and we are going to do the last round of public comment, which is on any other matter within this jurisdiction of the committee, but that's not on the agenda today. So same number, 415-655-0001, access code 2482-297-9271, then you press pound and then pound again. Got no callers. Since we've got no callers, I'm going to close public comment.
Thank you. So, this is the new timeline that we're just working from as a placeholder while we go through this design process between DPH and the IWG. You can see the next meeting, we're going to continue our conversation about the OCC, and we're going to hear from one of the programs from New Beds and Facilities, which is more of an update on where they are in relation to their recommendations. I believe it's going to be the Drug Sobering Center, but we will confirm that. We'll also probably get an update from the mapping and the retreat discussion groups. And I believe that we are going to be having a 3rd discussion group that's been added in community engagement. So that's actually 3 discussion groups to happen between now and the next meeting. Could you go to the next slide, Ash? So that's something to consider is when we send out all of the materials from this meeting, we'll include, like some of you had signed up for one work group and some of you are discussion group and some of you are participating in 2. And now that we have 3, there might be some adjustments that you want to make. So we will send out what we know right now. Please know that if you signed up for something and you want to switch around, you can, just let us know. We will do our usual thing where we schedule to the best of our ability with everyone's schedules through a polling app, and then we'll get those on the books. The next standing meeting is February 28th. It'll be a 4-hour meeting. We were going to cancel the meeting on the on March, but now we're keeping the meeting because that's actually going to be our retreat. So you can just disregard that bullet. The mapping discussion group is meeting on the 7th at 11:30. And the retreat planning discussion group, which many of you just signed up for, will be finding that date. And now there's a third one, that community engagement. We will be back in person in March. The meeting is going to be held at City Hall, as what we're thinking right now. We still have to secure the room. I think we have it, but we'll send that out too as soon as we can. And I note that I'm going to update the meetings that you have in your calendar. So you're going to get a cancellation of meetings starting in May. No, sorry, starting in April, because those all have webinars that are associated with them. So I'm going to cancel all those out, and we're going to set up a fresh one that are all going to be in person.
Jennifer, could I clarify something about the back in person? I just want
Yes.
to clarify that the remote participation is no longer an option when it's a requirement in person. It doesn't offer a hybrid, right? I just want to clarify it for
Yes.
everybody.
Yeah, there is no hybrid option. They say that barring disability, subject to reasonable accommodation, a health issue, or parenting leave, all IWG members are expected to attend meetings in person. So we still need to figure out with the public comment that relates to all of you, is how you participate, if it does need to be in person. We still need to talk about public comment. And if we're going to have public comment, we could still stream these meetings for accessibility. Like there's a couple of different things that we can talk about at our retreat to make this the best we can for folks. All right, any other comments before? Then I'm turning it back over to Chair Lazar again.
Thanks, everyone. Jamil, Vice Chair Patterson wanted to say thank you to you for always speaking from your heart and for showing up in all the ways that you do, and thanking each and every one of you for all of those things. I wanted to say that I'm really looking forward to seeing you all in person. If you are contemplating not re-upping your seats, as we still do have open seats, I really need the mayor's office to lean in to the mayor's office or to the city to get these appointments filled. So please do help us on that. I do have several names of community members, as do I'm sure other people as well, that would make a good person in these positions, but I think the recommendations have to come from the mayor's office. So we really do need your help, mayor's office, on that. And then also anticipating that some folks are letting us know that they may not be continuing. We definitely want to push that forward. So looking forward to seeing you all in February. Also seeing you all very soon in the working groups. And thank you very much, and happy Lunar New Year, and we'll see you all soon. I make a motion to adjourn.
Second.
And thank you. Thank you. Yes. And thank you very much to Harder and Company, to the Mayor's Office, to DPH, to everybody that participated. Incredible teamwork. Thank you all. Have a great rest of the day.
Thank you.
Bye.
Thank you. Thanks, Chair.